it is my pleasure then to introduce Zeff Koutsogiannis, who is an emergency physician and a clinical toxicologist and currently works at the Austin Hospital in Melbourne. He consults for the Victorian and New South Wales Poison Information Centres and is a member of the Victorian Addiction Inter-Hospital Liaison Association, VAADA. His professional interests include illicit drug use, substance use disorders and withdrawal states, acid-base disturbances, and the critically unwell toxicology patient. So thank you, Zeff, for joining us.
Thanks for the introduction. I will be pronouncing it Wernicke's, although technically it is Wernicke's because it's German, unless you drive a Volkswagen. I'm not sure. Okay, I'm a toxicologist at Victorian Poisons and at the Austin, and a disclaimer for today is that I'm actually on call. I couldn't get anyone. Somebody's covering me for this talk, but they won't be covering me for the whole day, so I may need to leave at some point, and apologies for that. I would like to stay for the whole day. Okay. So Wernicke's. I've been asked to talk about Wernicke's. I don't know whether I'm going to teach you anything new here, and I don't know how much Wernicke's you've seen or not seen, but we'll go through it, and I'm happy to be interrupted as I go along, and I'm happy to take as many questions as you like later. Vitamin B1 or thiamine is my favourite vitamin. I don't know whether you've got a favourite. It seems like vitamin C and vitamin D get all the glory, but I think vitamin B1 is probably the best. And that's because it's the only one that it's actually an emergency if you pick it, that it's going to be, you're deficient in it, you need to give it as soon as possible. Whereas the others, although you need to replace them, they can wait. A couple of disclaimers. I don't have shares in thiamine. Or vitamins. There will be one slide on biochemistry. Apologies for that. And I have been known to be a bit ataxic and have nystagmus and memory loss in the context of alcohol, but I've never had Wernicke's as far as I can remember. So some cases, just to think about things. Case 1, 55-year-old man, alcoholic, intoxicated. Let him sober up and he can go. He can walk, but he's a bit shaky and he seems quite ataxic when he walks. Now, I've used the term alcoholic just to see whether, to gauge the temperature of the room. Speaking to the AOD people, I don't know whether I'll be lynched by using non-patient-centered language, which we shouldn't be. And I may say the word alcoholic a couple of times during the talk in context of a few slides, but it's alcohol dependence or alcohol use disorder is probably better terminology. I just put that in to remind me. Case 2, guy in his 30s, recent withdrawal, and his wife brings back, said he's just not right. He just can't remember things like he used to. He's not back to his baseline. You've probably seen people like this. And case 3, 40-year-old man is sent into ED. He's got alcohol withdrawal. He's got normal vitals. He's got no tremor, but he's quite confused and his eyes are a bit funny. Just think about those cases. Okay, Wernicke's. The thing is, it's easy to miss, but easy to treat. So we need to think about it. If you think about it, you can treat it and it's all good. Whereas if you don't think about it, you don't treat and it can't be good. Bit more on terminology. Wet brain. I don't know whether you've heard of that term or you use that term, but it's an old term. People still use it. Wet brain is basically saying the chronic neurodegenerative changes in your brain because you've been drinking too much alcohol for a long period of time. It's not wet because your brain is actually edematous with fluid. It's just wet because they call it wet because of alcohol. Hence my t-shirt. Beriberi, you've probably heard of terms like beriberi, dry beriberi and wet beriberi. We don't tend to use those terms much. Some people still do, but we don't tend to. It's basically thiamine deficiency. Wet beriberi is thiamine deficiency that affects or the neuromuscular and neurology, peripheral neurological effects of being thiamine deficient. Beriberi is a Sinhalese term, which a lot of Southeast Asian population have been thiamine deficient, and that's because they're rice-based foods, and the rice that's been polished gets rid of all the nutrients and stuff. So brown rice is better than white rice. Hence, there's been a lot of thiamine deficiency over the years, and that's been recognised. And beriberi comes from a Sinhalese term meaning I'm tired, or I'm weak, sort of double word. If you're interested in double words, there's lots of them out there, like bye-bye and so-so and bora-bora and tuk-tuk and bon-bon. There are others. Feel free to talk to me about it afterwards. He is a German neurologist, I think he was a psychiatrist as well, who in 1881 noticed that people who drink a lot of alcohol, some of them tend to have ophthalmoplegia, gait disturbances and confusion. And when they die, he did autopsies on them and found that they had certain punctate hemorrhages in certain parts of the brain around the third and fourth ventricles and the aqueducts. So he termed it that this is a thing. The guy on the right is Sergei Korsakov, who a few years later, unrelated to Wernicke, noticed that people who drink a lot of alcohol over a long period of time have problems with their memory, and the problems with their memory is so bad that it's out of keeping the Korsakoff syndrome. I don't think they ever met, and I don't think they realized that they were part of the same syndrome, and they certainly didn't realize that this was due to thiamine deficiency. They just went, alcohol causes these things. So Wernicke-Korsakoff syndrome, we didn't start calling it that until the 50s. In the 30s and 40s, it started becoming clear that maybe this is a thiamine problem. And then we started thinking, well, maybe this is actually the same disease, but seeing it at different times. So think about it as different stages of the same disease, but two different syndromes, if you like. And it wasn't until the 50s where in the medical literature, they started calling it Wernicke's-Korsakoff syndrome. So Wernicke's is acute and reversible if you get onto it quickly, and Korsakoff's is chronic and you're left with it. It's the consequences of not treating Wernicke's. And all this is a spectrum. Some people are really bad and some people are not so bad, but they've still got that Wernicke's-Korsakoff deficiency. How common is it? Well, it's hard to know, because if we miss it a lot, then how do you know? So some figures say in Australia it's about 3% of the population, and having an alcohol use disorder makes up more than 80% of them, and that's where we're here today, and that's where we see it mostly. But we'll talk about where else we could see Wernicke's as well. If you're left untreated, mortality is quite high, and in fact, being institutionalized, if you progress from Wernicke's to Korsakoff's and not being able to look after yourself, can be quite high as well. But those figures, depends on what you look at, can vary. It's more common in men than it is in women, but it's more common in women in terms of the ratio of how many women are alcohol dependent and how many women get Wernicke's. So there are more women who get Wernicke's compared to how many women are alcohol dependent as there are men. And that's got to do with body size, nutrition and stuff. The average age of onset's about 50, but it ranges from 30 to 70. And we'll just pause here to talk a bit about vitamins, because not many people know what vitamins are. How are we going for time? Where is it? Is there a clock so I know what I'm doing? Sorry, because I can crap on. So vitamins are defined as something that is essential to the body and the body doesn't make. and therefore you have to consume it. You have to have it in your diet or some sort of supplements to have it because you don't make it. And there are 13 of them. There are 4 fat-soluble ones, and the rest are water-soluble, which are all the B vitamins and vitamin C. This is Casimir Funk, great name, Polish biochemist who got interested in the concept of vitamins, or what he called them vital amines, because they're vital for the body. And that's where the word vitamins come from. And the company that he worked for many years later, because thiamine had a sulfur group in it, which is a thio. Sorry, awesome. That's true, sorry. They called it thiamine, as in a thiol group vital amine, or thiamine. Yeah, discovered it in 1911, which is the first vitamin to be discovered. So B is for brain, and the brain, even though is a small part of the body in terms of its size, it actually takes up a lot of energy, like 1/5 of the body's energy. And I don't know whether you've noticed on a day that you've been thinking a lot, you're just exhausted and you think, I haven't done anything today, but you've just been concentrating, you're just tired. That's why. So let's meet the B team. You probably noticed there that it goes from B1 to B12, and they were numbered in order of how they were discovered. There are only 8 of them there, even though it goes from B1 to B12, and that's because 4 of them, they thought they were vitamins at the time of the discovery. Then they realised that actually they don't meet the definition because either the body produced them or they weren't actually that essential as they thought. So B4 doesn't exist, and B8 and B10 and stuff. So B1 is the one that we're talking about today, thiamine. So where do you get thiamine from? Greens. You've got to eat your greens, and anything that comes from a pig. So pork and ham and bacon and stuff. So grain and grains, cereals and grains. What do? They all do special things to the nervous system and with energy and metabolism, and they all work in different parts of the body. So here is the one and only biochemistry slide. Apologies. So glucose gets metabolized down to pyruvate in one pathway, and then through a variety of mechanisms. And these 3 are the 3 enzymes that are thiamine-dependent enzymes that are very important in these mechanisms. But using the Krebs cycle, so the Krebs cycle is where we make ATP and energy, and the pentose phosphate pathway on the right is where the body, there's a lot of cellular metabolism making nucleic acids and DNA and RNA and all those sorts of things. And those 3 enzymes are the main enzymes involved in cellular metabolism and energy production. In fact, Krebs died in November 22, which is today's date, in 1881, just as a fact. Just in case you go into a pub trivia night and it comes up tonight. So simplifying it, they're the 3 enzymes there, the transketolase and ketoglutarate dehydrogenase and pyruvate dehydrogenase. So what does all this mean? It just means no thiamine, which means no Krebs cycle or pentose phosphate pathway, which means you don't produce ATP and your cells are not happy, and then the brain doesn't like it, and the brain doesn't like it, and it gets broken down and toxic, and the part of the brain that it affects will start not having function. So energy production, cell growth and function, and producing myelin, which is important for nerves, just go out the window. And that can happen pretty quickly. How much do you need? Well, it's probably closer to 1 to 2 milligrams, but I put 1 to 5 milligrams a day. So then you ask, so why are the tablets 100 milligram tablets? And that's because you only absorb 5% of it. So that's why. So if you give somebody 1 milligram, they're not going to absorb anything. Foods are different. So milligrams of thiamine in foods, the body tends to like and can use easy, but exogenous supplements, it only absorbs 5%. It'd be nice if they were called thiamine and riboflavin, but they're not. They're called B1 and B2. And I put that slide up because they came to our screen in 1992, and 1992 is when the government in Australia decided to fortify flour and cereals, realising that we needed thiamine from other sources. Because when we make, so grains have got thiamine, but when you process grains to make cereal, it gets rid of all the nutrients. Like rice, you go from the rice husk, brown rice thing, and then they polish it and get rid of all the stuff, and all the thiamine goes. So they fortify rice as well. So 1992 is when we started fortifying flour and grains. There was talk back then around fortifying beer. I don't know whether anyone's been involved in that. So the concept being, you know, this is an alcohol problem, then why don't we just put thiamine in the beer? And that was quite controversial, partly because alcohol affects how thiamine's absorbed, and we'll talk about a bit later. Part of it is you could just see the campaigns of healthy beer, have some, and it probably wouldn't have made a difference. So the fortification of beer doesn't happen. Possibly, I don't know, but it's the same. It'll be the same deal. Yeah. So there is thiamine in bananas, but you have to eat 100 of them in a day to get your thiamine supply. Just speaking of bananas. Eating your greens is important, but green bananas that make a difference. So just thought I'll let you know. Can you take too much? The answer is no. Vitamins, you just weigh it out, particularly the water-soluble ones. So if you eat a healthy diet and you take supplements, it's probably a waste of time and a waste of money because you're just going to be paying it out. If your diet's not great and you're at risk of vitamin deficiencies, then sure. But the more vitamins you take, if you don't use it, you just pay it out. So the body, if you eat a healthy diet and you're rich in all your nutrients and then you stop eating, you've got about 3 weeks of storage. And after that, you need to start eating nutrients to get back on track. And if you give someone 100 milligrams of thiamine, it gives you about a week's worth of thiamine supply. So that's good. That's why we give 100 milligrams of thiamine to, I guess, I don't know what your practice is for most people that need to come into hospital who are otherwise well, who happen to be at risk of thiamine deficiency. You just say, well, you know, you don't have Wernicke, you don't have Korsakoffs, you're just a person in hospital who's possibly thiamine deficient. I'll give you 100 milligrams of thiamine, and that'll give you a week's worth. So what causes thiamine deficiency? Diet, clearly, how you absorb it and how you lose it. So the conditions that do this, the number one is, and while we hear alcohol dependence, alcohol use disorder, but there are other conditions out there that are less recognized, like eating disorders, people with anorexia particularly, fad diets, people do some crazy diets out there, bariatric surgery, which is becoming a big thing. A lot of people are getting a lot of surgery for their obesity. And there's a whole lot of protocols with regards to giving them thiamine because you take out, you either do a Roux-en-Y bypass or you do a gastric sleeve, and that affects how you absorb thiamine as well. So they're very prone to thiamine deficient. Hyperemesis in pregnancy and just having cancer, being cachectic and not eating, and you're at risk of lots of nutritional stuff. So how does alcohol do it? Well, poor nutrition is one of them. So, I mean, the spectrum of, as you know, alcohol dependence is quite large. You can go from the classic alcoholic who just sits there and just drinks all day, doesn't eat anything, and gets all the calories from alcohol, and that's it, to the sort of functioning 2 bottles of red wine a day, but they sort of eat well as well. So they just got that. They probably get gout too, probably. But poor nutrition is one way. If alcohol interferes how your body absorbs thiamine, so if you take your thiamine supplements and drink alcohol, you won't absorb the thiamine very well because alcohol sort of impairs the absorption. So taking a Barocca while you're still pissed probably doesn't work. Just putting it out there. you're prone of not storing it. Alcohol makes the kidney lose it, so you pee it out more. And if you have excess thiamine, you pee out the excess. But if you don't have excess, you still pee out thiamine in the presence of alcohol. And increased demand means at times of alcohol intoxication or at times of alcohol withdrawal, that's when the body uses a lot of thiamine. So withdrawal states in particular, which is when I guess you guys will be seeing people are prone of getting Wernicke's. But it's not just thiamine with people who are alcohol dependent and nutritionally challenged. All the vitamins, you know, that's why people who don't look after them. So it's all the vitamins that they're having issues with. How do you diagnose it? Well, you need to think of it to diagnose it. If you don't think of it, you probably will miss it. I mean, I don't know how you guys diagnose. It'd be nice to have a conversation later about what your criteria are. But the classic triad is this: eye signs, confusion, and ataxia. And the problem that people have is only 30% of people with Wernicke's have eye signs, only 80% have confusion, only 25% have ataxia, and only 10 to 15% have all three. So you get taught that these are the classic triad of Wernicke's, and because well, yes, there is a better way. This article came out 30 years ago. I'm not sure when. When was it? 97. So 27 years ago. Kane criteria. I don't know. Do you guys use the Kane criteria? Do you know what I'm talking about? So Kane said you got four things. You got dietary deficiency, so somebody who looks like they're nutritionally challenged. Oculomotor abnormalities, and it varies from can't move your eyes at all to the common thing is just nystagmus. But you can get palsies of your eyes that you can't actually look to the side. And sometimes they just look funny. You just go, why are your eyes funny? Can you move your eyes? You know. Cerebellar dysfunction, which is basically an ataxic gait, or they're a bit wonky. And if they're altered in any way from a memory or a confusion point of view. And if you have 2 out of those 4, then you pick it up about 85% of the time. It's still not 100%. But it's better than relying on I'm going to wait for the classic triad to come up. So, but then you say, hold on, nystagmus, ataxic gait, altered, that's just drunk. Aren't they just drunk? They are. They can be when they come into the emergency department, but as you sober up, these things should disappear. So a drunk person who's, 0.4 and now he's 0.2, but they're actually fine and say, can I go home? Because they're alcohol dependent and they can handle 0.2, they should be walking okay, and eyes should be okay, and they shouldn't be confused. Whereas if they sobering up and they're like this, I'm thinking that doesn't make sense. So it should resolve. So if you're ever wondering to be or not to be, then it's to be. I've put this up because this is Patrick Stewart doing To Be or Not to Be on Sesame Street. And I put him up because it's a famous soliloquy of to be to not to be on Sesame Street, but also that his dad was, as he puts it, an alcoholic, and he's been quite vocal in promoting helping people with alcohol use disorder during his career. So sometimes you just go, there's something not right about this person. I'm not sure. If you're asking could they have Wernicke's, then just treat them like they've got Wernicke's. You've got more to lose if you don't. And the treatment is thiamine, as soon as possible. Now, the treatment's also not drinking. So part of their recovery, so you bring them into hospital, you give them all this thiamine and they get better. They can get better quite quickly. Part of that is because they're not drinking as well. So the dose. Now, that's controversial. I don't know what doses you use. When I was a boy, the medical school textbooks would say 100 milligrams a day. That's what they used to say. And a lot of people still believe, and it's probably true, that that's probably enough. Um, and then people started talking about, but maybe you need more for Wernicke's. You know, maybe 100 days okay, but maybe you need more for Wernicke's. Then it became 200, and then it became 300, and now the guidelines are variable from 250 to 500 3 times a day. It makes sense because you need to, your receptors for thiamine into the brain are saturated, so you need passive diffusion. So the bigger concentration in your blood, the more thiamine gets flooded into the brain. So it makes sense. But how much does that concentration need to be to get through? I'm a simple guy. I think 300 is enough. 300, 3 days. 300 3 times a day for 3 days is easy to remember in my book. But if you look at lots of guidelines, you look at therapeutic guidelines, it'll say, 300 to 500 3 times a day. And then after that, it's 300 daily for at least 3 days. Some people say 5 days, some people say a week to 2 weeks, but it's at least 3 days, and you'll see some sort of recovery in that time. The problem is, I think St. Vincent's, I don't even know, I worked in St. Vincent's a long time ago, did a study about looking at high dose thiamine, whether it made a difference, and they never got enough numbers to make a conclusion from it. But what they did conclude from it is that it exhausted the hospital supply of thiamine. Because if you give someone 500 TDS, that's 5 vials 3 times, that's 15 vials per patient that you suspect has got Wernicke's. That's a lot of vials. If you got 4 or 5 of those, and St. Vincent's is a place where a lot of people with alcohol used to sort of go. If you have, 4 or 5 of those people in any one time, then that's a lot. That's 60 vials a day. So what's the downside then? Well, the pros is that it's cheap and it's safe and it's available. So therefore, what's the big deal? Why finesse the 100 milligrams versus 300 milligrams? And that's true. So that's why high dose is stuck, and it's in all the guidelines now. So whether you believe high dose is a good thing or not a good thing, it doesn't matter, because all the guidelines say that's what we should be doing, and it's a bit hard to go against it. And then you don't do it, and then someone gets permanently neurologically damaged, then you go, it's because you didn't give high dose thiamine. So I think we're stuck with giving it, but I don't think we need to give 500 TDS personally. I think 300 is enough. And the cons is, obviously, if you don't do it, then you get permanent damage. Some people at high doses are more prone to getting like anaphylactic type reactions, but that's unusual, and that shouldn't stop you from using high dose thiamine. We're going for time. IM. So I'm not sure what setting you guys use. So maybe you don't have access to IV, and IM's okay, but usually they're thin with poor muscle mass, they're coagulopathic, it's less reliable absorption and less desirable than IV. But if that's all you've got, then IM is good. But bearing in mind that 500 IM is 2 injections. It's not 1 injection because it's 5 mils. So that's why 300 is good, because 300 you can give 3 mils IM, and that's 1 injection. So that's why I like 300 as well. Don't forget magnesium. So all these thiamine-dependent enzymes and all these processes need magnesium to work properly. Thiamine will work, but if you have magnesium, it'll work better. And if you're in a hospital setting and somebody's really got, like, you're thinking, oh, they've got the full triad, they're Wernicke's for sure, then I'd just give it IV, just give big doses IV. But you can just give it orally as well if you're in a non-hospital setting. But don't forget the magnesium. And they should start getting better. The eye signs remarkably can get better within hours, and within a day they could be gone. So somebody could have nystagmus, so really wonky in the eyes. You give them thiamine and their eyes are better within a day. The ataxia confusion starts getting better within a week, but may take a month or so to get better. And obviously, the longer you leave it and the longer you've had Wernicke's for, the more likely that you won't recover from it, and therefore you get chronic Korsakoffs. So Korsakoffs, it's the characteristics is amnesia and confabulation, and they confabulate because they're just making things up because they can't remember anything. They're just making it up because this is how they negotiate the world. And remember, their other higher cognitive functions are not too bad, but memory in particular, retrograde and antegrade are not good. So, and they're confident about it. Yeah, that's what it is. Yeah. And I remember being a medical student listening to someone with Korsakov's, and I'm just going, oh, yeah, having this conversation. And then the consultant goes, what do you think? I said, yeah, it's good stories, blah, blah, blah. He goes, no, it's all crap. It's just because they're confident and it comes across like it's true. So when you ask somebody with Korsakov's, what color is this string? If you don't have Korsakov's, you say, what are you talking about? Korsakov's will say it's green. They'll just lie, or they're not lying as such. They're just making it up. So does anyone know where this steals from? No, it's not Jimmy. Huh? So is it? It's last weekend, yeah. 1945 Billy Wilder film with Ray Milland, who's on the left. It's about an alcoholic writer who was meant to go away with some family from memory and decided to just pop into a bar for a bit, and then just basically lost the whole weekend just drinking because he was a hopeless alcoholic. And the reason why I've got that there is because the coat rack is quite a bit of a symbol and a metaphor in a lot of these movies, where it's a metaphor for your troubles and your woes and your traumas. You just take your coat off and put it on the coat rack, and for a period of time you have a few drinks and you just forget about it, and it's like a crutch. But it's also, you see it in a lot of movies, isn't it? It's classic. You walk into a bar, you take your hat and coat off, you put on the coat rack, and then you start drinking. The reason I got it there is because if you like mnemonics, then coat rack is a good one to remember. Some things about what Wernicke's is and what Korsakov's is. So Wernicke's is the classic triad of confusion, of thermoplegia and ataxia, and of course thiamine is implicated. And Korsakov's is retrograde and antegrade amnesia and confabulation, and the psychosis that comes with it. So the take-home point is think about it and treat with high-dose thiamine. And I'm happy to take questions in a pill form or in a food form. Thank you. It's earlier. I was allocated 45 minutes, but no one can speak for 45 minutes, can they? Anyway, these days with short attention spans. Anyway.
Thanks, Zeff. Well done. Really appreciate that. So we do have a question in the room, and we may have a question or two coming in online.
Hi, I'm just wondering in terms of with the thiamine, if you've got 300, say, and it's obviously preferred with IV, but in the ED setting, obviously, if they're being seen and then discharged later, obviously you'll be opportunistic in the administration initially. But if they're going home, do you just go with the oral for 300 then for 3 days?
Yeah, so if you think they got thiamines, they shouldn't, if you think they got Wernicke's, they shouldn't be going home because they need high-dose thiamine for at least 3 days.
Yeah.
So if Wernicke's is the diagnosis, then they should stay in hospital.
Yeah.
Becomes tricky when they don't want to stay and all that sort of stuff. But you can't sort of go, oh, I think they got Wernicke's. Here's a dose of thiamine, off you go. I know they need to stay because it's an emergency and it's acute, and you need to treat them.
Yeah. Cool. Thank you.
Although having said that, it's a good question, because although absorption is limited to 5%, there have been some studies out there where people have given people like 1,000 milligrams orally to absorb at least a lot of that somehow. So I'm not saying that's an outpatient option, but that might be an option for some people in certain settings.
You have another one? Pleasure.
No, I was just wondering what happens next. Like, they've been in hospital for their 3 days of IV. They go home. Most of our clients go home.
deficient the brain is of thiamine over a long period of time. So if you've treated them for 2 or 3 days and they've come good, then that's great. Although it'd be nice to keep going and give them a bit more thiamine. I mean, some people do recover within 2 or 3 days. It's just that a lot of people don't. If they go back drinking, that's the problem. Some of these patients do have alcohol-related brain injury, which sometimes you can't pick up clinically, and you have to have neuropsych testing and so forth. But if you go back drinking, then the chances of having this slow burn Wernicke is increased.
Hang on. No, we're going to let you need to use the microphone, Jody. Sorry. And you need to put it close to your mouth.
Yes. Unlike me for most of the talk. Apologies.
I think it was good that you said just giving them the 100 milligrams IV gives them a boost for about a regardless.
I mean, like I said, there are different alcohol-dependent people. Some people you just go, oh, you don't need it all. You haven't eaten greens forever, and you'll be nutritionally challenged. And other people, they come in because they've had a fall, and you know that they're alcohol-dependent and they're intoxicated today, who drink 2 bottles of wine, but they actually can still work and have healthy meals. So I'm not so fussed about those ones particularly, but it's not a bad practice to give them 100 milligrams of thiamine.
Okay, Sharon, we've got, in fairness to our online colleagues, we'll come back to you. Anushka, can I give you the microphone?
Got a couple of questions from our online attendees. So Sarah's asking, what's the recommendation for before switching to 100 milligrams regularly, or suggestions for inconsistent use of thiamine?
Yeah, I don't think you need high doses to prevent it. You just need doses to prevent it. And if you don't have Wernicke's and you give regular doses, then that's enough.
Thank you. And I've just got one more. What is the bioavailability of IV versus oral?
Well, IV is 100% because it's IV. You just give it straight in and the thiamine's in your body. Whereas oral, you ingest it and you only absorb 5% of it. Yep.
Sorry, just a quick one. How does alcohol prevent the absorption of thiamine?
Yeah, so alcohol affects the villi in your gut as well. So a lot of people who drink alcohol probably have, diarrhea. I don't know whether anyone's had a big night, but the next day is not, so I'm told. And it also affects the transporter as well. The transporter doesn't work as well in the presence of alcohol.
Thanks, Zeff. Anushka and our online colleagues, are you all good? One more, thank you.
Kate's asking, in our residential withdrawal unit, we dose 100 mg daily for 3 days. Is that inadequate in the absence of obvious Wernicke's?
Yeah, probably. I mean, they're in there for, 7 days? Is it 7 to 10 days? 7 days? Yeah, I think that's good practice. Yep.
Another one. Thanks, Sharon.
I'm going to ask a really facetious question here. Can I have your phone number, please, so that when I've got clients, patients in the hospital who cannot get admitted for 3 hours, let alone 3 days, how can we help these people? Because if they're admitted at all, they might be kept overnight if they're lucky. So,
And they've got Wernicke's? Because if
often
they don't have Wernicke's, then
we don't know because they're discharged before we can even get to see them.
yeah.
So how do the serious question is, how do we get physicians in hospitals to take this seriously?
That's a good question. The reason why I'm standing up here as a toxicologist, not as an addiction specialist, is because where I work at the Austin, there weren't any inpatient addiction services. So therefore, people who had alcohol and drug problems that required admission, they just went, no one wanted them, no one looked after them. So the toxicology service decided that we're going to do it. We've stopped doing it now because we had like 1,000 referrals in 4 years, and that's not our core business. Our core business is overdoses and poisonings. Now we're getting fledgling addiction medicine liaison services. But you're right. Part of it's education. And a lot of this comes down to bias and judgment and prejudice. So, yeah, we see that even in our department, with our tox service being advocates for patients like this, even then there's judgment and they don't get treated well and all that sort of stuff. So how do you change it? You change it from, I guess, from the ED up, because where do they go? They present to the emergency department, you're saying, and then they go.
Well, sometimes, but other times they'll be admitted. They might have been admitted for something else, and that's when, we might catch them as part of the addiction liaison service. So we might actually catch them, and they're the fortunate ones. But often the ones who come in through ED with intoxicated, once they're below 0.1 or whatever the number de jour is, they go, and we may never know. And so it's really difficult. And even if someone is lucky enough to get admitted, they may only stay overnight or for a day. And it doesn't matter what we say, they will be discharged.
But do you have, I don't know, a powerful person in your group that runs your service that could have meetings at a high level to talk about it? Yeah, or do you have addiction medicine specialists who are all over this and therefore they can speak to the inpatient units?
2 days a week we do, yes. We've also got a nurse practitioner candidate who was going twice a week, every week, to ED to provide education. To get the doctors to turn up is almost impossible, and to get the nursing staff to try and advocate with, and they've got a really high turnover of nursing staff. So,
are these patients in the emergency department or they get admitted to short stay?
Usually in the emergency department.
Because I was saying if they went to short stay, at least you could say anyone who gets admitted to short stay for an alcohol-related problem can't be discharged unless they get seen by you or something like that. I can give you my number, but I don't think it's going to make a difference. They're not. Why would they listen to me? Yeah. Yeah.
I've actually found. So number one, I've stopped worrying about pissing people off. Number two, I try to write my notes in a way that the doctors will respect. So I will write things like high risk of thiamine deficiency, not safe for discharge, and I also will write requires X number of doses of thiamine as per our alcohol withdrawal protocol. And often what I find in our hospital at least is it's the more junior doctors that are coming down to do the admissions, they see that. And I'm like the expert, even though I don't think I am on some respect, but when you actually speak in their language and someone says they're not safe for discharge, then it actually puts it back on them to go, all right, I want to discharge them, but this person's saying they're not safe. And usually it might result in them being kept for an extra day or something like that before they ignore me completely, but at least they're getting a number of doses of IV thiamine.
Thanks, Daniel. At the risk of just going a couple of minutes over, Zeff, did you want to touch on, would you mind touching on methanol and the current context in Laos and from a toxicology perspective?
I can. Do you want to do it now, do you? Yeah.
Well, I'm just conscious that you may be called away.
I haven't got anything prepared. I was only asked about this last night about it. I don't know. What do you want me to say? Well, I mean, it's tragic. I think there's a fifth person that's just died this morning. Outbreaks of methanol have been common for many years. It seems to be, Southeast Asia seems to be a popular place where this happens. Bali, Indonesia, Thailand, Laos, Cambodia, it's all been implicated. Even Turkey and as far as the Middle East. Now, methanol is they're all alcohols, like ethanol is an alcohol and methanol is an alcohol, but methanol and ethylene glycol, which is a separate thing, brake fluid and radiator fluid stuff, don't worry about that. But methanol is it's a toxic alcohol, and in itself, it's not toxic, but its metabolites are toxic. So it gets metabolized by alcohol dehydrogenase like ethanol does to formaldehyde, and then formaldehyde gets metabolized by aldehyde dehydrogenase to formic acid, and you get acidosis, coma, and blindness, essentially, because the formic acid affects your eyes. So why does it happen? Well, who knows really why it happens, but if you do home brew or distill spirits, if you don't do it properly, because the first part of the process of the liquid that comes out is basically pure methanol, and you're meant to discard that before you left with your ethanol, and a lot of places don't. That's one way, so poor distillation. Another thing is in a lot of these Southeast Asian countries that are poor, they use methanol to just boost the local drinks to make it go further, because methanol is cheaper to produce than ethanol is, so they just mix the ethanol with the ethanol to make it as potent as ethanol, because you can't really taste it, so you drink and you just get drunk. That's pretty much really it. And it's tragic because ethanol inhibits alcohol dehydrogenase. So alcohol dehydrogenase metabolizes ethanol. So while ethanol is in your body, the alcohol dehydrogenase enzyme is metabolizing ethanol. And once all your ethanol is gone, you start metabolizing methanol and you get the toxicity. So we treat methanol toxicity with ethanol, or fameprazole, which is another antidote, which is much better. But we give people, we take calls about query methanol poisonings, and we just say, go to the local bottle shop, put a nasogastric in, give them 4 shots of vodka, and then 1 shot of vodka every hour, and then we'll come and see them. So that's the treatment. So that's why if you go out drinking, you don't know for 12, 24 hours because you haven't metabolized the methanol yet. And then you start metabolizing methanol and you start feeling shit, and then your eyes go a bit funny. And then if it's really bad, because you only need 0.5 to 1 mil per kilo to kill you. So if you're 50 kilos and you have 50 mils of methanol, you can die. I don't know how much they put in these drinks, and a lot of this is backpacker, cheap, young person traveling, trying to have a good time. They're not going to go to a highfalutin bar where cocktails are Australian prices, because that's not why you're there. You're there to have a good time. Yeah. That's sort of in a nutshell. Yeah.
No, you answered mine, because tea room chit chat yesterday, we were talking about vodka's the antidote for the methanol. And I was just like, but that makes sense what you just said. Thanks.
But it's really hard to know, because you have to be about 0.1 to 0.15 to block the enzyme to stop metabolizing methanol. And, if you don't know what you're doing, you can't really.
Thank you. All right, sorry, I'm going to get in trouble very quickly.
So, is methanol, is it the same as methylated spirits, or has methanol got something else in it?
No, methylated spirits is about 95% ethanol.
Ethanol?
Yep.
Oh, okay. Righto.
And
that's all right.
5% like a bittering agent to make it taste shit, so you don't drink it unless you're really hardcore.
Okay.
So commercial supermarket methylated spirits is ethanol. There's no methanol in it. Methanol you find in industrial stuff, paint strippers,
window
cleaners, all that sort of stuff. But in terms of methylated spirits, it's called methylated spirits because it used to be methanol back in the day, but it hasn't been methanol for, 30, 40 years. It's just ethanol. So you can drink methylated spirits if you want, and not go blind in the.
Please thank Zeff for his insights, knowledge and wisdom.
And it's my great pleasure to introduce your next speaker on methamphetamines and pregnancy, the challenges and the opportunities. So I'm introducing Elvira Earthstar. Elvira is a clinical midwife consultant specialising in perinatal substance use. and her career has encompassed family violence, nursing, midwifery and drug and alcohol recovery work, and she delivers training and advice to clinicians across Victoria on providing evidence-based pregnancy care to those with complex substance use. Elvira is a member of the newly developed First 1000 Days programme, a multidisciplinary team approach at the Royal Women's Hospital, providing extended medical and allied healthcare to infants exposed to drug and alcohol in the womb. Even in the most complex of circumstances, babies come into this world ready to love and to be loved. Through her work, Elvira has learned time and time again that profound positive change in individuals and families is not only possible, but likely. Welcome.
Sort out my tech. That sounds like that's working. Yep, very good. All right. Yes, great. Two things working. So excuse me, I am going to refer to my notes as I go along. It's so great to see everybody here and to hear that there's another several dozen people online. I'm always excited when people are interested in this, what is quite a niche area. I get to do it sort of day in, day out, but I realise that for many of you here who are from the drug and alcohol sector, it would be less common that you're working with people who are pregnant. But it's just so crucial, I think, that everyone who works with families, everyone who's working in drugs and alcohol is really familiar with this unique time in someone's life. So first of all, I'd like to acknowledge that we're gathered today on unceded Wurundjeri land and acknowledge the lands of the people who are joining online. At the Women's, I have the privilege to work with and learn from the world's oldest living culture. And I honour elders past, present and emerging. I acknowledge that sovereignty was never ceded and this always was and always will be Aboriginal land. And also that many of us who work in drugs and alcohol and who see Aboriginal clients, really what we're dealing with is the intergenerational trauma of colonisation and genocide. And also what I have the part of the work that I like doing with my Aboriginal clients and colleagues is learning about the deep resilience and connection and healing that is also part of Aboriginal culture. And it's particularly apparent when we're working with mums and babies. So today what I'm going to talk a little bit about is this is a very short snapshot. I'm here for I've got about a half an hour talk, and then we're going to have some time for questions. And I'm always interested to hear what you're interested to know about. I'm going to start talking about the Australian context of methamphetamines, a tiny bit about the pharmacology, but in particular how that relates to physiology in pregnancy. Is everyone here a nurse, or have we got a mix of nurses and social workers? And hands up, anyone who's not a nurse? Okay, great. Most people here have some physiology. That's good. We'll talk a little bit about the treatment options for people with methamphetamine dependence in pregnancy, outcomes for children and a timeline for intervention. And one of the things that I like people to know is that certainly in the media and broader society, and I guess all of you would know the impact of stigma and of this being seen as like a too hard problem, parents using drugs, that is just too hard, that can't happen. Look, people with drug dependencies can and do get pregnant. They can and do become parents. It's not an intractable problem. It's not, people who meet you when they are in the midst of an addiction may well walk away in a very different part of their lives, and that's what we're aiming to do in our work. So probably a lot of, hands up here, anyone who works with people who are using methamphetamines? Great, everyone. So I don't need to do too much about what that looks like in Australia, but certainly from looking at the international literature, it seems like in particular Australia has a larger cohort of people who are using methamphetamines. It seems that intravenous use is more common here than other places in the world. It seems that dependent use is more common here. So what that means for us working in a maternity hospital is that there's actually not a lot of research for us to refer to internationally. A lot of the research about pregnancy and drug exposures is much more focused on opiates, and there's very little in the way of methamphetamines, pregnancy, and then outcomes for children. There is some though. We have been collecting data in our service for the last 5 years in a pretty systematic way. A table that I don't have here, but is really interesting, sort of shows that, our service, the Women's Alcohol and Drug Service, was set up in the 80s to support women who were using heroin. 15 years ago, in 2010, primarily the patients that we were looking after were heroin dependent. That's not the case anymore. So you can see our cohort of, this is about which drugs babies are exposed to. And so infants are exposed to a variety of drugs, the ones that we see. We've moved from primarily heroin exposed infants who have a very particular medical course to much more methamphetamine and cannabis exposed infants. And what has been unique for our service is that with infants who are exposed to methamphetamines, there is very likely to be another 1 or 2 classes of drugs that they're exposed to. So polysubstance use is much more common in the women that we're seeing than it was 15 years ago when women would be just using heroin. So our infants are exposed to a variety of different substances. We're seeing a little bit of opioids still, a little bit of heroin use still, some people on treatment, but that's been going down the last 4 years. Last year we only had 11 babies where the mum was on either methadone or buprenorphine. That's really different to where things were 15 years ago. We're seeing sort of still ongoing alcohol exposures. GHB is emerging. There is absolutely zero literature on the impacts of GHB on the developing fetal brain. There are no studies at all. So we don't know what we're dealing with. Benzos these days we're seeing less commonly than we used to. All right. But so when we're doing education these days, we're focusing a bit more on methamphetamines. It poses some pretty unique risks in pregnancy, but it's also a time with pretty unique opportunities. So we know that 44% of Australians who have really regular methamphetamine use live with a mental illness. Mental illness being both a cause and a consequence of ice use. It's common to see people who are actively using to present with emotional dysregulation, heightened anxiety, a lot of anger, depression, and also suicidal ideation. Now, when we're working with them, these are women who are trying their best to get to pregnancy appointments, to come and have ultrasounds, to keep it together for a day in hospital that might involve 5 hours, multiple blood tests, and speaking to 3 or 4 different people about their lives. So I'm always sort of astonished at how much our women are able to tolerate. Who might come, they can't cope with everything one day, but we know that they're going to be back within a few days or within a couple of weeks. We know that methamphetamines have neurological impacts in adults. So in adults who have dependent use, some of you may have seen people who are presenting with, shaking hands with symptoms similar to Parkinson's. And that is thought to be related to this repeated overstimulation of the dopaminergic system. We don't really know what that does to the developing fetal brain, but we do run a follow-up clinic for babies for up to 2 years, and we do see our babies come back with it will be really interesting to sort of keep track of these babies. The cardiac risks of methamphetamine use are of particular importance in pregnancy. The heart has a lot of extra work to do in pregnancy. It's providing circulation for two, and we have a vastly increased blood volume particularly in the third trimester of pregnancy. So anyone who's pregnant in their third trimester will have up to 1.5 litres extra blood. So having a heart that is working hard already with a pregnancy, if we're then bringing methamphetamines into that system, that can be really concerning. The psychosocial impacts of dependent methamphetamine in pregnancy and early parenting, that is the time when we need our social relationships the most. It is, everyone needs their village around them when they have their baby, and it is really challenging for our women whose village might be a group of people who have very little in the way of extra support to give them. So part of what we try and do is look at who's around, are there ways in which your social relationships can be improved during pregnancy. So with that in mind, I want to talk a little bit about why it's so important to focus on pregnancy. And part of it is just about the community impact. If we're investing in children, we know that has benefits across the lifespan. We know that, spending $1 on supporting a child in early life will save $20 further down the track. And ideally, investing in children starts before conception. It starts with having healthy parents who are coming into this with an improved capacity to welcome this child into their lives. There was also a study that came out earlier this year that had found that over 40% of Australia's poor mental health, and in particular suicidality, has child maltreatment as its cause. Child maltreatment is there is more we can be doing as a society to prevent child maltreatment, and working with mums during pregnancy is a big part of that. So that's part of why we think focusing on substance use in pregnancy is really important for the community. It's also really important for the individual. It's a time when we see really increased motivation with mums, and it's really touching to see just how much the people that we're working with can achieve. And these are often people whose lives are really substantially impacted by their substance use, but they find ways to get up and they often are engaging with our service when they perhaps haven't been able to engage in any other way. It's an opportunity to engage you with healthcare regularly. So if you're coming in to see a doctor and a midwife regularly for your pregnancy, it's also a time when you can be looking at your nutrition, your dental health, skin health, and we can do some great harm minimisation work with people even before they're ready to start thinking about stopping. And also it's a time when both community services and family and community systems come into play. So we do, as a society, really value babies, and we often see this as a pregnancy is a time when relationships that had previously been ruptured will be starting to repair. Mum or auntie starts coming back on board. There are connections with people who have got the interests of this child at heart. This is my favourite bit of the talks that I do. We talk about the placenta. The placenta is my favourite organ. So the placenta is the life support system for a baby. This diagram here, so we've got, for those of you who haven't done pregnancy physiology for a while, we've got the uterus here, which is a great big muscle. Got a lovely healthy term baby right here with the umbilical cord and the placenta embedded right into the wall of the uterus there. Now, mother and baby don't share a blood circulation. mothers and babies can and do have different blood types. So everything that gets into and out of the baby during pregnancy is going through the placenta. So oxygen and nutrients from the mum flow from maternal circulation into the intervillous space, which is this space between the two different circulations here, and then they're picked up by the fetal circulation, go through the umbilical cord and into the baby. Having a really even flow of oxygen, nutrients and waste across the placenta is reliant on mum having stable blood pressure and a normal dilation of her blood vessels. So methamphetamines affects the blood flow across the placenta. When the mum's heart rate and blood pressure increase because she's taking stimulants really regularly, then there's a change in the pressure gradient at that intervillous space there. And that means that there's a reduction of this flow of oxygen and nutrients into the baby and waste away from the baby. That's why we see babies who are affected by, babies who are exposed to methamphetamines throughout the pregnancy will often be a bit smaller. They'll often be born a little bit earlier. And it's in part because of that continuous challenge to the mother's blood pressure and the impact that has on her placenta's functioning. The other important thing to know about the placenta is that psychoactive substances like methamphetamines pass freely between maternal and fetal circulations. So they are molecules that are small enough to cross the blood-brain barrier, which means that they are molecules that are small enough to then get across the placenta. So the fetus is receiving the same effective dose as the mother. So the impacts of methamphetamine use on the baby include the impact of meth on the mother's circulation and the placental functioning, as well as the impact of the methamphetamine itself on the developing fetal brain. There are a range of pregnancy complications that we see in mums who are using methamphetamine in a dependent or regular way. The most important one of this is insufficient antenatal care. And if there's any take home that I want you all to take back out into your practice, it is anyone who is pregnant needs to come for pregnancy care as early as possible. And it does not matter if you're still using or not. Coming for pregnancy care, we can start to improve the situation immediately, even if you've got no thoughts of stopping using. We do see too many women who are trying to get things together by themselves and say, well, I'll come in for my pregnancy care once I've got this sorted. They're leaving it too late. They're coming in very late in their pregnancy, if at all. And that's where we see really poor outcomes. We can also see worsening mental health in pregnancy. It's a time of great anxiety for many women because there's suddenly pressure on to have everything sorted within a few months' time. We can see problems with blood pressure, so hypertension is common, particularly in the third trimester of pregnancy. If you then add a stimulant on top of that, that's really challenging for the mother. We can see situations where if women have either preeclampsia, which is a blood pressure disorder of pregnancy, or hypertension, and they're then taking stimulants, they're starting to become at risk of seizures or strokes. We can see a hemorrhage. So the blood pressure problems that I'm talking about can then lead to part of the placenta coming away, which then leads to bleeding early at any point in pregnancy, or even a placental abruption where the placenta comes away, which is an emergency and will often lead to the death of the baby unless you're already in hospital when it happens. And so we can also see stillbirth as well. However, there are real opportunities to work with women who are pregnant and who are using methamphetamines on a regular basis. One of them is there can be a re-emergence of hope and hope for a changed life. A lot of women, even in the midst of the chaos, will have a sense, maybe tenuous to begin with, but can often be increased, particularly with supportive care, a sense of responsibility and connection to their baby. And I think part of the great joy of being a midwife in this space is seeing women really regularly, talking with them about their bump growing, talking to them about what are you going to name your baby and what do you notice about the movements, and helping her to really tune into the fact that she is growing a baby, and that she's the most meaningful person in the world to this baby. So the $1 million question that everyone always wants to know is, can I keep my baby in my care? And so we've had a look back over our statistics for the last 4 years. I think we had about 360 odd methamphetamine exposed babies. Now, nearly half of those babies went home in their mum's care. So yes, it can and does happen. And so this is babies who might have been exposed at any point. We haven't broken it down by trimester. But yes, it is possible for mums who've had methamphetamine use during their pregnancy to go on and become, really loving, stable and attentive, attuned parents. That said, if their substance use is unaddressed and remains the focus of their life, they're not able then to tune into their babies and provide adequate care. So it sort of depends who in our team you ask. Some of us will say, oh, more than half of our babies are removed. And I'm like, well, nearly half of our babies go home in their parents' care. So glass half full, glass half empty. But the women who do take their babies home in their care will pretty much universally say, I would not have stopped using if I was not pregnant. I was not ready, and this was the push. And I think so many of our families are able to do something for someone else. They're able to do something for their baby that they haven't been able to do for themselves. And that's really special. So it's really important for people who don't work in the pregnancy space to sort of know what pregnancy care is. And, it's available right across the state, public and private. And pregnancy care can be with a midwife, a GP or an obstetrician. Ideally, it should be someone that you see regularly throughout your pregnancy. It's an opportunity to have health conversations that are centered on the pregnancy rather than just, and a lot of that is about, well, what's going right in your life? How is this panning out for you? How are you feeling? How are your relationships? And it's, conversations that then, some of it is about the problems that our women are facing, but some of it is about the things that they're proudest of and happiest about. The goal of antenatal care for everyone is that the mum and baby survive, that the pregnancy lasts until full term, which is sort of 37 to 42 weeks. The baby's really well grown. Family has capacity to parent safely, that we can see a warm and organised attachment, and to support the transition to early parenthood. And what I want everyone with current substance use to know is you don't have to have your life in order to turn up for pregnancy care. Coming for pregnancy care is a big part of preparing to be a parent. And ideally, women with complex pregnancies, and that absolutely includes women who are using methamphetamines, they all should start their pregnancy care in the first trimester. So women may or may not be ready to stop using when they first come in for their pregnancy care. But even for women who continue to use, we can be arranging regular ultrasounds to monitor the growth for her pregnancy. We can be recommending vitamins and supplements and give advice. And all of that stuff is really meaningful. Realistically, not everyone that we see is able to cease their methamphetamine use. But pregnancy care will always make a difference and will always result in a better outcome than not coming for pregnancy care. There are a range of barriers for coming for antenatal care. Some of them are modifiable by the healthcare system. So in particular, stigma and fear of judgment is the most important one. And so particularly when I speak with midwives and doctors, I want them to know to meet people with respect and to treat people as they would want to be treated, and to honour and respect the that someone who is pregnant is other barriers to antenatal care can include set appointment times, competing responsibilities. And so having maternity services that are able to be flexible is really important, but also having other community services who are able to support women to come in makes a really big difference. So anyone who works in an outreach capacity, if you've ever got a pregnant patient, I would so encourage you to offer to bring them along for their pregnancy appointments. It makes such a difference. You know, if you're walking into a hospital and you feel like crap because you think you're going to be judged and, you know, everyone's going to start talking about taking your baby away, it's really hard to sit in a waiting room for 45 minutes just waiting. If you've got someone that you know and trust who can sit alongside you, to stay and sort of get all the things done that they need to happen in that day. As much as possible, having continuity of care makes a really big difference as well. You know, I know that people are here from all over Victoria, so some places we have continuity of care models available and others we don't. But even if it's a drug and alcohol worker or a healthy mother's healthy baby worker, someone who can stick with that woman throughout her pregnancy will make a big difference to her ability to attend. And care teams make a big difference. So I'm sure many of you here participate in care teams. And that's fantastic for women who have got a range of people around, if those people are then able to talk with each other. All right. So treatment in pregnancy. Methamphetamine is particularly challenging because with heroin we have got some fantastic, safe, approved treatments. There's now a variety of them that are safe to use in pregnancy. Methamphetamines, we have got nothing in terms of pharmacotherapy that is safe and approved for pregnancy. It is really a matter of doing the hard work and working towards stopping. Now, it is safe. From a pregnancy perspective, it is safe to cease methamphetamines cold turkey. And a lot of people come in saying, I know I can't stop because it would endanger my pregnancy. It's understandable where that's come from because certainly with heavy alcohol use and with heroin use, it is not safe to go cold turkey and you need a lot of medical support to safely transition off. For methamphetamine use, yes, you can. Clinically, what I see is that for most women, they do not stop cold turkey. For some of them, they will stop cold turkey as soon as they find out they're pregnant. But for those who are continuing to use into the pregnancy, they might need to reduce over time. And what we tend to see is that the women who are using methamphetamine are typically using other substances as well. And what they will usually do is stop using the substances in order of which they are most concerned. So they will typically stop using ice first, then they might stop, well, no, they'll stop using GHB first, then they'll stop using ice, then they'll start working on their cannabis. And if we get through all of that, they might start to think about smoking and vaping. Counselling can help enormously. Relapse prevention, all of our strategies that we have as a sector can be of use. Detox can be a fantastic containing space. And I can see we've got Rose here who we work with really closely. There are a couple of units in Victoria that do take pregnant women right up until, you know, partway through the third trimester. So it can be safe to go to an inpatient detox facility. And rehab as well. We've got a couple of rehabs in Victoria where you can be pregnant and also where you can take your baby with you and remain with your baby. I guess there are a range of treatments that are available, and the best one, the gold standard, is the one that the mum is willing to do, because we can come up with all the plans in the world and say what we think might be effective, but if you haven't got the person on board, it's not going to work. Again, that's why it's important to have strong and trusting relationships. Outcomes for newborns. Some of them are related to the complexities of preterm birth. So perhaps needing admission to a nursery to grow and get bigger, and needing developmental support. However, even our babies who are born at term, who make it past that 37-week mark, they're much more likely to be small and vulnerable babies. They're much more likely to have feeding issues due to a lack of coordination, particularly in their jaw. You know, newborn babies have to work out their suck, swallow, breathe. It is quite an effort for them to get going with their feeding, and babies who are withdrawing from methamphetamines often just don't have it in them. They might need a period of nasogastric feeding to support their growth for a few weeks. And what we can see then is babies who need these sorts of treatment can then be admitted to a nursery. Now, certainly at the Women's, and I think it's the same across NICUs across the state, is that there's not rooming in side by side. So then there's that disruption of attachment where the family can't stay by the baby's side 24 hours a day. So caring for our newborns, we do monitor for signs of withdrawal. We don't have a perfect system for monitoring. The system that we use was developed for opiates. But look, it is pretty clear a baby who is going through withdrawals will let you know. Either they'll be sort of hitting the roof, they'll be really jittery, really stressed and not organised, or they'll be really lethargic and not able to feed effectively. So we do aim to keep mothers and babies together where possible. So for, keep them on the postnatal ward for 5 days or so. If we've worked with a woman and she's not currently using, she's ceased during pregnancy, and look, often we'll do some urine drug screens in the 3rd trimester to really establish that evidence base that the use has stopped. And if we've seen methamphetamine use stop, then we absolutely support breastfeeding. It's the healthiest food for babies. And we want to keep that attachment going as much as possible and support mums to be with their bubs. There's no medication, and often the withdrawals are self-resolving. Outcomes for children. So what we see in our paediatric clinic is it is common to see developmental delays, particularly around speech and communication, and also around muscle tone. We can see behavioural issues in the 2nd year as they move into toddlerhood, and issues with emotional regulation. Now, part of this is perhaps the methamphetamine exposure. Part of it is also what these kids are expected to deal with in their first couple of years of life. And that could mean a home environment where they don't have attuned caregivers. It could also mean that they've been put in multiple different foster placements and they're really struggling with their attachment because they've been home with mum and they've been removed, and then that didn't work out and they're somewhere else, and then they're with a kinship placement. What's best for babies is for them to be in a family situation that is continuous and they know their caregivers. So we run a clinic, we've started a clinic at the Royal Women's Hospital called the First 1,000 Days. So the WADS program's been around for a long time, working with mums in pregnancy. We used to see the babies for, 6 weeks or 3 months afterwards to check that their growth was going okay. But what we know from some of the international research is that, particularly with methamphetamine exposed infants, development can be normal in the first little while, but in the 2nd year we can start to see some issues that are really modifiable and that can respond really well to treatment if we've got the right people around. The first first 1,000 days is the time of greatest neurological potential in our lives. It's the time from conception until a child turns 2. This is the time where we see most brain growth. It's the time where we grow the most brain cells, and also where we do a lot of pruning, where we work out whether the world is safe and our caregivers are reliable, or whether they are not. So we see our children up to the age of 2. We have a paediatrician, a developmentalist, midwife, social worker, and we're getting speech pathology and some infant mental health support. And that really aims to provide really wraparound support to these babies, no matter what their family situations look like. Yeah, and we say methamphetamine exposed children are at risk of lifelong developmental delays. So we don't wait and see anymore whether there are early signs. As soon as we see that there are early signs of developmental delays, we start intervention with allied health. And we're seeing really good outcomes with that. So for many of our families, the birth of a new baby is the beginning of a new life entirely. And a lot of our mums bring their babies back. They're really proud, and it's really lovely to see them and go, gosh, you know, remember when you first came in for your first pregnancy appointment and you were so anxious and so stressed and you didn't know where you were going, and look at you now. You know, it's a really rewarding part of my work. I hope people can read this from where they're sitting. This is a really fantastic little chart looking at what are some of the problems associated with methamphetamine use, and then what interventions can and should happen when. So before conception, you know, if you're working with people of reproductive age, talk to them about contraception. Talk to them about not having an unplanned pregnancy, if that's what they're wanting. Support their nutrition, support them gaining stability. During pregnancy, you can work on encouraging pregnancy visits and, you know, harm minimisation. Harm minimisation is really effective. You know, it makes so much difference if a baby is exposed to ice once a week compared to twice a day throughout their gestation. That makes a real difference, and it is worth doing. We're working with babies. We can ensure that they're getting the right nutrition early in life. We can support them with any problems that they're presented with. And during childhood, providing developmental screening and family support. For those of you who do work with families, there's some fantastic training on emerging minds about having conversations with your clients that keep the children front of mind. And if you're working with parents, it's always really important to be talking about their kids and how they're going, because kids can be left out, but they're also parents' greatest source of pride and of potential for change and improvement. So my final thoughts are there's no single treatment for methamphetamine's use in pregnancy, but we all have a role to play, and that investing in these families and in these kids can make a difference across the generations. So I hope that you would feel confident to work with these families to put children at the centre of your practice. And do I have one more slide? Yes. And if you are working with families and you'd like more support or you're interested in this topic, please do get in touch. So our service runs, we have a duty line. You can ring, you know, business hours anytime and speak with a midwife or a social worker and get some advice, run through a case with us, talk to us about our clinical practice guidelines. We're really wanting to make sure people are providing evidence-based treatment and support to their patients. And we run an ECHO program. You know, small but really important group of people. So I think we've got a little bit of time for questions. Thank you for your attention. Yeah.
Just in terms of logistically, I suppose a question more so for yourself, being a midwife working in the space. Obviously, patients, clients are our forefront that we advocate for, and we work hard to work with them, foster hope, all that kind of stuff. But in terms of when you're coming to potentially really chaotic home environments where you've got, you know, a fetus in utero, and then once they're born, in terms of if the home environment still seems really unsafe, that there's pre-contemplation around wanting to address it, and the home environment isn't the best. Where do things stand logistically in terms of kind of the therapeutic relationship you've built then?
Yeah. I mean, that's one of the toughest questions. And I think for a lot of our patients, it's really clear that things are not okay, and it's, you definitely need to make a notification to Child Protection. And it's when it's that grey area where there's some strengths, there's some capacities, but there's also some concerns. I mean, look, our perspective is that infants have no way of speaking up, and that they are reliant on the adults around them. Child protection involvement does not mean automatic removal of a child. And, we do see, anyone who works with child protection will know that there is perhaps you can't that the home environment may not be safe for them. I would always err on, and that can't be addressed through other routes. I would always err on making a notification, because if that baby goes into that home and there are known safety risks, and the child's not coping, that infant has no way at all of notifying anybody else that that's what's happening. Yeah.
Wondering, are the what's referral zone? So just say you've got somebody who lives in, yeah, they could probably hear me.
Yeah.
If someone lived in Sunshine,
yeah,
would you have to be referring to, say, a Sunshine Hospital that's got a not the same program but has a program there, or do you take them from anywhere?
We take women who come to the women's hospital, and so that so we do see women from a very broad area. So for most women, going to their local maternity hospital is best. Sunshine is looking at setting up a fairly similar program. So there are programs that are kind of similar to WADS at the Mercy and at Monash and at Box Hill. Sunshine is in the process of setting up their own. I guess there's no hard and fast rule to that. We can take women who are
I just know that if I was pregnant, God forbid, no, my daughter was living in Atwood and she wasn't able to go to the women's.
Yeah.
Because she's out of zone.
Yeah.
She did. She came to my place instead.
Yeah,
but
lots
that's
of people
another
do
story.
that. Yeah.
And I just wondered whether it was similar with WADS referrals.
No, it's a bit more flexible with WADS referrals because it's a bit patchier in terms of where the level of what specialist clinics people can access, depending on where they live. And that's the same for all sorts of clinics at the women's. You might be zoned to the Werribee Mercy, but actually your baby's got a cardiac issue, so you're going to come to the women's to come to our MFM. So we're a specialist clinic. If you meet the criteria and there's nowhere close by,
cool,
then that might work.
We had that question came up the other day.
Yeah. Sometimes it is safer for women to go to their local maternity hospital because it's close, and then you've got to get the care team happening in the community.
You're more likely to attend appointments if you don't have to travel a long way. But I just wondered. Thanks.
Yeah. Ages ago, we used to take people from all across Victoria and they didn't come. So the aim is for the whole of the state to be able to provide expert care. Yeah.
Have we got any questions online? All right. Well, Zeff, do you want one more? I think there was none.
And then we'll have to wrap up, or else we'll get
Thanks for your
behind.
talk. My question's twofold. One is, what's the recurrence rate of using methamphetamine again once you've stopped when you're pregnant?
Yeah.
And in terms of, is it any different to any other person who stops using methamphetamine and then goes back using again? Is pregnancy like protective in any way? Or?
Yeah, look, pregnancy is very protective because if you stop using during your pregnancy, you're very likely to maintain that for the duration of the pregnancy. you know, the women that we work with, almost all of them have child protection involvement, even if they stop using in the first trimester. They know that if there's a slip up or a relapse, that their child
But
will probably
duration
be
of
removed.
pregnancy is different from once the baby's born, then what?
Yeah. Well, look, a lot of our women maintain sobriety for months and months, and some of them permanently. So yes, pregnancy and parenting is protective against relapse, and there's a lot of evidence around that for a variety of substances internationally. It's a time when your whole life changes as well. So it's like all of the other patterns in your life change, from where you go, what time you get up to, you know, all of those other things that can be really hard and really entrenched to change in the absence of a pregnancy or a child. So there are sort of other things around it.
And the second part is, do the women who are pregnant come to your program any different to any other pregnant woman who uses methamphetamine in other programs in terms of relapses?
Well, I'm not sure if anyone else is doing that research or.
What I'm saying is your program special because it prevents recurrence compared to just
I mean, we'd love to think we have that much influence and power with our patients. But I think that having like the extended sort of 2-year support, we think it will be protective against relapse, or that if there's a lapse, that then we'll be able to sort of keep supporting and get things back on track. We don't have the data to back that up, but you know, I think that the evidence around extended care for people in early recovery is pretty clear that it helps. Yeah.
Okay, now that we need to move on, I'd just like to thank Elvira for her fantastic interesting topic, and that we've now got the resources that we can contact you and know where the programme is. Now I'd like to invite VAADA up to introduce our next speaker.
Yeah. Thank you. So my name's Felda. I'm currently working as an AOD CNC in Sunshine ED Hub. Just a quick comment about this morning. Listening to Zeff's talk about Wernicke's, I was born in Germany, so I'll pronounce it Wernicke's. It takes me back to working in the UK in the 90s, where there was a family that successfully sued a hospital for failing to recognise that their loved one had Wernicke's, and they failed to treat it, and he developed Korsakoff's. He was in his 30s and required 24/7 long-term care for the rest of his life. And the health authority back in the 90s ended up paying over £1 million to the family for that care. That led to changes in the medical training in the UK, where the triad of symptoms was changed to any one of those symptoms you treat and suspect Wernicke's. And my last role prior to coming to Australia, I was in commissioning and funding of services. So the cost of treating a suspected Wernicke's far outweighs the cost of long-term care for someone with Korsakoff's. So on to our next session, Pathways to Nurse Practitioner and OAT Updates, Micro-inductions. Can I just get a show of hands in the room? Anyone who is an MP? 2. Anyone on the pathway to training as an MP? No. Okay. Or maybe. Okay. So Meg is the Senior Addictions Nurse Practitioner for Alfred Health, covering consultation and liaison addictions and South City Clinic. She is also leading a pilot project with Access Health in St Kilda to increase opioid pharmacotherapy access in the southeastern suburbs of Melbourne. She has experience across both acute and community services in mental health and AOD treatment, including within ED's acute psychiatric inpatient units, consultation and liaison, homeless outreach and project management. Meg has a particular interest in improving access to acute care for patients with substance use disorders and developing systems which promote flexible models of care to meet the needs of individual patients. This includes building harm reduction into acute care as part of core business, rather than relying on AOD services to provide these interventions. Please welcome Meg.
Is this turned on? Oh, amazing. Anyone who knows me should know that they should never give me a microphone. I probably don't need it, but I've been told I have to wear it. And also, I think my bio needs to be seriously rewritten, because I think it just also now represents the chaos of who I am, which in trying to put together this presentation, I was thinking about all of the various domains that I work in, and I'm sure my other nurse practitioner colleagues in the room can sympathise that it's really hard to define what we do day to day. So I've kind of tried to break it down into what my pathway and journey into NP has been and where I've ended up today, and then into a more interesting topic about stuff that I'm very passionate about at the moment, which is micro-inductions into buprenorphine. So let's get into it. Oh, there I am. I'm going to do an acknowledgement because I like my newly redone one, which is Alfred Health respectfully acknowledges the traditional custodians of this land, the people of the Kulin Nations. We pay our respects to their elders past and present. We acknowledge and uphold their continuing connection to land and waterways. We would like to acknowledge the land's first healers and the importance of community and culture in traditional healing processes. There's so many screens for me. This is insane. All right. So in terms of nurse practitioners in Australia, I tried to really break it down because it's not surprising to me that there isn't a huge number of NPs in this room, because we are a small breed of the nursing workforce, but we are a small but mighty and growing part of the workforce. And as you can see from the numbers here, at the moment across Australia, in terms of principal place of practice, we have 2,930 nurse practitioners currently functioning, which if I think back then to like the ANMF membership, which I think has pushed past 60 or 70,000 now just for Victoria, the MP workforce is tiny. So I'm very passionate about growing this workforce because we are critical within the system, and within AOD, we have a very important role to play. And more specifically, how NPs in particular in AOD have evolved over the years has been a bit of a journey. But across the world as well, and NP models of care internationally are quite different to what we have in Australia. So our MPs working in New Zealand, in the UK, their roles are a little bit different to what we have in Australia. But they've been around since the 1960s, and it wasn't until 2000 that we had our first NP endorsed in Australia. And having gone through some of the previous endorsement processes, and you'll feel my mild chip on my shoulder about this, how things were back then in terms of endorsement and classification and the training requirements and the committees we would have to present in front of and the various panels, and Rose is laughing because she's been through this as well, is very different to what we have today. And I'll say that as a very important caveat because it was really intimidating for a long time to try and get your endorsement through as a nurse practitioner. And things are slowly changing as we have more nurse practitioners built into the workforce. But then it wasn't until 2004, so not long after our first NP, that we had our first NP in the AOD specialty. But only as of 2019, we had 41 NPs in the AOD sector compared to 168 in our mental health colleagues. So big differences between where the workforce is spread out for nurse practitioners across Australia. The highest number of NPs do exist still in our emergency departments, and part of the reason for this is around defining what a nurse practitioner can do and where they fit within the system. For a long time, part of what we had to do is prove a gap in service provision, and it's about finding tangible things that the nurse practitioner workforce could do that was different to our medical counterparts. And I think that's really important because we get really fixated and focused on being able to prescribe and diagnose, and a lot of what we do as NPs is so much more than that. And that's where I think we really should focus more, particularly within the AOD sector. The reality is, though, in terms of how we define ourselves as nurse practitioners. And there has been changes to this, but one of the big difficulties we face in all reality is that we don't have NPs built within the workforce matrix. So it's not established anywhere that we have X amount of CNCs, X amount of NPs, and X amount of ENs. It is just, oh, one would kind of work there. So let's put an NP in there. And then we get into problems with sustainability and succession planning. And for a long time, there was this view that we were, for want of a better term, the cheap version of a medical officer, which is not what we do. I would argue at times we do much better work than my medical officer colleagues, but that's how the operational systems would view us. So we had to prove our worth, and we had to prove what we could do that was different, that was beyond just prescribing and diagnostics in nurse practitioners. Is the pathway and why my decision making to become an NP is a little bit convoluted. And back here in this photo in 2019, I had been a nurse practitioner candidate, then left a nurse practitioner candidate position to go back to a CNC position, to then argue with a new health service to be an NP, was endorsed with APRA as an NP, but not currently working as an NP. And this is one of the challenges we face, is that we have this workforce of people who are endorsed as NPs in this space, but cannot find employment because there aren't matrices that set out how many NPs we have within the nursing workforce. The ACNP, defines that what an NP as a career choice should be made for multiple different reasons around improving health outcomes, making positive impacts, ensuring evidence-based practice, delivery of patient-focused care, becoming a specialist with AOD CNC. I got really tired of having to ask for permission, if I'm brutally honest. I would make recommendations in the ED around certain treatment regimes, and registrars would come on and say, no, where's the registrar to tell me to do that? And I'll be like, I've been working in AOD for a very long time now. I have a master's of addiction medicine. I know what I'm talking about. This patient does need these dosing regimes, and they would challenge me on it, who had no AOD experience. And then when I moved to the Alfred into a very senior CNC role within the addiction service at the Alfred, what would happen is I would make my recommendations, and we had general medicine registrars working with us. And the home unit would then call my general medicine registrar, who didn't know anything about AOD, and that was their first week of rotation, and say, hi, your CNC has recommended 40 milligrams of methadone for this patient. The registrar would then call me and say, hi, you've recommended 40 milligrams of methadone for this patient. What should I tell the home unit? 40 milligrams of methadone for this patient, please. And then it would go through this cycle of communication. I got tired of it. I got brutally tired of it because I knew that I could do this work. And I also started to realise that as a nurse practitioner, I would have more autonomy to work assertively with my patient group. And I'm very passionate about improving access, as it said, to acute care. And what we do know in AOD is that people with substance use disorders face huge amounts of stigma within the healthcare system. It doesn't matter how much training we do. I know I'm preaching to the converted here, but they face stigma and stereotyping all the time. And I thought, if I'm an MP, I can make a bigger difference to my patients as well as just prescribing my own methadone. So the NP pathway seems straightforward, but it is a journey. And there is key requirements that people need to have in order to go down this pathway. So of course you need to be an RN, register with APRA, and then you must prove now 5,000 hours at 3 years, full-time experience at a senior level. Now this is an interesting point. This doesn't mean managers can go off and be NPs. So it must be proof that you're working at an advanced clinical practice level in a senior position. So I could argue when I was working in an autonomous role in the ED as a grade 4 nurse that whilst it wasn't necessarily hugely senior, I was working autonomously, independently, doing my own work within the broader units, that counted towards my experience. But my manager, for example, wouldn't be able to argue the same thing because it's an operational line. You then either have two options. You can go through an NMBA approved master's program of study, or you can go off and do it as a non-approved pathway. Ultimately, you still need to do a master's program. It's just which pathway you take in order to do that. Pathway 1 is arguably the easier one because that's an NP endorsed master's program, but pathway 2 means you've done another master's of some description in nursing, and then you need to add on your pharmacology and higher diagnostic subjects to make the standards up. So as I was saying, when we're talking about advanced clinical practice, it's more than just the grading of positions. It's recognition that lots of nurses are functioning out there in senior roles that doesn't necessarily get reflected by their grading in the position. But more, they need to be involved in quality improvement, treatment planning and research, and all these things build into those standards of care as a nurse practitioner. So then we also have these annoying I say that facetiously, a nurse practitioner candidate positions, not everyone going through their training is in an NPC position. So lots of people go off, and this is what I ultimately ended up doing, starting a nurse practitioner training program, not being in an endorsed NPC role, which meant at the completion of my training, there was no requirement for my organisation to employ me as a nurse practitioner. Whereas if you're in an NPC role, there is a requirement and a commitment from that organisation to support you with all of your supervision requirements, your training needs, as well as at the completion and endorsement with APRA, that you'll actually be given an NP role within your service. But there aren't many of these about. So how do we get past all of this? The biggest advice I give anyone is how do we find a gap that an NP can be reasonably put into that gap? And there is so many places in drug and alcohol where this works, and it's beyond just opiate pharmacotherapy. What is it that we could do to bridge that gap with an incredibly senior nurse that can't be otherwise filled by a registrar? Because that's often the argument that gets put back at us. So of course, the obvious examples are opioid agonist treatment. But there's other ways that we can do that. That's not just sitting in a clinic in a primary healthcare service doing methadone and buprenorphine. Is it ways that we access it within the hospital system? Is it that you're functioning out of another community site and you just want to opportunistically be able to engage people around opiate pharmacotherapy? Is it something to do with Hep C treatment or the other physical health needs around people who use drugs that aren't currently being met by your service? Is it to do with hard to reach populations? Is it to do with First Nations people? Is it people with multiple complexities? These are all the spaces that nurse practitioners function incredibly well because we work with the complexity, we work with the difficulties of these presentations and are very comfortable with it because we're senior nurses in this space. So I remember at the time taking a photo, and again, here's my chip on my shoulder because I know the course has changed, but I remember when I did my pharmacology program and my room in my house turned into like the Beautiful Mind. If you've seen that movie and all the stuff on the walls, that was my house going through pharmacology. There was every pharmacology pathway, every different form of pharmacological action and pharmacokinetics, because that was a very stressful time at 6 months of your life. And any MP that went through that program at the time, which has changed, will tell you the same thing, that they probably lost their life for 6 months and it just became all about medicines, which I don't think is necessarily a bad thing because I learned so much in that course. And as you'll see from the second part of my presentation, I love pharmacology because it tells me why I'm doing the things I do. It makes things make sense. I don't just randomly pick medicines and go, that feels right. Sometimes do, but no. It gives me definition behind it. But in short, over 2 years as a full-time student is how long it takes to get towards being an NP. I don't know anyone really that's done it in 2 years. How long did you take, Rose? Oh, you're good. I think I was 3.5, 4 as well. Most people don't try and do it in 2 years. It's way too much workload because of also the supervision and the support requirements that you need to get through during that program. But if you get into an NPC role, that means that the organisation has to support you for all of that time as well and provide you the adequate supervision during that period and time for studies at uni. Oh, here's my beautiful mind. Is it worth it? Absolutely, is it worth it? I would never change my decision around becoming a nurse practitioner, and I think anyone who's slightly inkling towards going towards a nurse practitioner should actually go down that pathway. It's incredibly rewarding. It gives much greater recognition to the work that I do. I think many of us can agree that within AOD and addictions, we work very nicely within a very flat hierarchy with our medical peers in most cases, and so this puts us on a really good even playing ground with a lot of my colleagues that recognise the specialty that I bring that's different to that of my medical colleagues. It means that I do get to function very autonomously. A lot of the work that I do, and I'll try in a minute to conceptualise what a day-to-day week looks like for me, because it is more than just prescribing. It's around so many other things that I get to do with my clients that in terms of like assertive outreach, really grassroots style work that I know that my colleagues in medicine don't do. And as I said at the start, there used to be all these hoops and barriers that we would have to jump through to try and become nurse practitioners, which is slowly changing over time. I couldn't find the actual picture, but this is remarkably similar to when I got endorsed. I had to sit in this boardroom at the Alfred, surrounded by 15 executives of the Alfred, nursing executives, and then basically argue with them as to why I should be a nurse practitioner because they didn't want to give the funding for the role. And I think that went on for about half an hour of advocacy as to why my position should be converted. And what's fantastic is that I recently supported one of my nurse practitioner candidates to go to this very same panel, A, it's now online. B, it took her 30 seconds. C, I think she got one question asked for her, which is fantastic. I have a mild chip on my shoulder. It's rather large, but it's fantastic that things are progressing to the point that if we have established nurse practitioners, we have pathways in place for them, that these processes are becoming much, much less daunting because there is greater acceptance of nurse pracs in the workforce. So this was my pathway, which as you can see is a little bit odd, and every single nurse prac will have a slightly different role, even if they're functioning in similar style clinics. I started out my nurse prac candidate pathway when I was working in ED as an AOD nurse. I'm pretty sure, Daniel, you were around for when I started that. And when the very first EdClan, does EdClan still exist? Yep, very first EdClan time was when I was doing this. And I had to argue with my hospital at the time to do this MPC. And then I realised very quickly that I was really isolated. And so I didn't get enough training and exposure to specialists that I wanted to have access to. So I left my hospital at the time and went over to the Alfred thinking that I was joining this massive big addiction medicine service. It was me and one session of consultant. But I had to go back into a CNC position. They didn't have an MPC role for me at the time, and then spent the next 2 years arguing with them around whether or not I could convert into an NP when I'd finalised my training, which eventually they did. I did go through a 12-month period of time of being a CNC endorsed with APRA, but not yet practising. And then after that, I moved into various different NP roles within alcohol and other drugs. From CL addictions, I worked out at the injecting rooms for a period of time, have now refocused as well on AOD and sexual health, and have recently moved into the senior nurse practitioner role for Alfred Health across our organisation as the clinical lead. So it's been quite a journey to lead me to this is the ridiculously simple conceptualisation of my day-to-day week. I tried to do it as clearly as I could because when I looked at my actual calendar, I went, that makes no sense because my jobs are so varied. I work well in a sort of place of chaos and that's okay with me. But I guess what I'm trying to portray here is that all the roles are so different. What it really appeals to me as a nurse practitioner within AOD is I get a lot of ability to change things. When I notice new gaps, I can start to address, excuse me, new gaps. And then if I'm getting tired of my non-clinical workload, I then have relief because I work in a clinic now. And when I'm in clinic, I'm seeing usually now between 15 to 20 patients a day. And so I get this balance between non-clinical systems work and then my very complex work in clinic. So I'm not going to do questions yet because I understand I'm under time pressure. So we'll move away from nurse practitioners. There's enough of them. And let's talk about more interesting things to do with buprenorphine and micro-induction. Now, nurse practitioners, great. All right, so I just need to disclose that I have a financial relationship with Camurus, a pharmaceutical company that has an interest in the subject matter being discussed today. They're not affiliated with my presentation in any way, shape or form. And whilst I am committed to providing evidence-based information, it's important to acknowledge this relationship for the purposes of transparency, as we will be discussing off-label prescribing. So let's talk about buprenorphine. Buprenorphine, as I hope you all know, is a partial mu opioid agonist. It has a lower receptor activation with a plateau effect. One of the things that we all love about buprenorphine is its safety profile, and it's because of its pharmacological action that we love it so much. And because it's got this massive safety profile, because of its affinity and its competitiveness for these receptors, it means that starting treatment can be quite tricky at times. And this is why we've had different models for inductions onto buprenorphine over the years. One of the key things with buprenorphine treatment is that it isn't for everyone. It won't produce the same euphoric effects as things like methadone, heroin or morphine will, but that's why it's so safe as well, is because of its partial agonist activity. We know that part of the reason we like it so much is it's got a decreased risk of overdose, decreased risk of diversion, greater ability for dosing flexibility now because we had LAIB arrive at such a timely time as COVID hit, and so we were able to get them out of pharmacies and out of GP clinics more rapidly. For a long time as well, many clinics were offering LAIB as a free option of treatment, which my clinic definitely still offers it free of charge. Arrangements, people can come in every 3 days or every 5 days or every 7 days or every 6 weeks, meant that we were trying to get more and more patients across to buprenorphine. But we all know the difficulties of getting people onto buprenorphine. So because of this very competitive partial agonist activity and its displacement of other opioids, if we administer it too closely to full agonist opioids, we get precipitated withdrawal. And so for some patients, our standard model of induction is very straightforward and they can manage that, and that's okay. And the kind of conventional ways we do this is either ask them to wait until they go into withdrawal, then we add in the buprenorphine. In the hospital system, for a long time now, we've been rotating people off their long-acting opioids and putting them onto short-acting opioids, so oxycodone or morphine, waiting for that to displace the leftover methadone across to buprenorphine. They've come off their methadone, returned to heroin use, then gone into withdrawal to go onto buprenorphine treatment. So as you can see, all of these pathways via the conventional induction system are fraught with risks, because a lot of it relies on the person at any given time going into withdrawal before they can start their buprenorphine program. We haven't seen this as much in Victoria, but I know up in New South Wales and Queensland for a period of time, they did a process which was called macro-dosing, where they load at the front end 32 milligrams of buprenorphine as quickly as possible and then wait for that to taper off. We don't tend to do that in Victoria though. So this idea of buprenorphine micro-inductions came about, and we actually learnt this of what was happening in Northern America in the fentanyl crisis. We didn't really have a need or a push to do micro-inductions before what started happening in North America. Absorbed, it gets stored in the fat tissue and adipose tissue of people. So as the fentanyl started to hit in America, they would wait there 2 or 3 days for them to go into withdrawal coming off fentanyl, and then they wouldn't withdraw. And they'd wait another day and they still weren't withdrawing. So day 5 comes around and they go, all right, we'll just start the buprenorphine. They're not in withdrawal, but it's 5 days, it's fentanyl, surely it's gone by now. And then unfortunately, what was happening is they were starting to send people into precipitated withdrawal because they still had so much storage of this fentanyl in their bodies. And so they came up with this idea, which was known initially as the Bernese induction, where they started to microdose in buprenorphine in response to these patients who were struggling to get across from fentanyl. And since that time, since the original Bernese induction model, there's been a vast array of different trials and ways to look at how we do micro-inductions. There's been case study reports in Australia, there's been a lot of trials over in America and in Canada, and so there's gaining momentum as to how we can actually implement microdosing more rapidly into our populations in Australia. And there's multiple different models of how we do this now, because one of the big problems we have is we don't have a national or a state-based consensus as yet. It is coming on how we would do a micro-induction. And part of the problem for this is that a lot of our buprenorphine products that we use in a micro-induction require off-label or private prescriptions, because our 2 major drugs that we'll use is transdermal Norspam patches or sublingual microdoses of Subutex you can use, but even they can be, the doses can be slightly too high, or Temgesic sublingual doses. And so all of these are not PBS indicated for opiate pharmacotherapy, and so we need to think creatively around how we use these products. But the same principle remains, and a picture I've put up there, I couldn't find one on the internet, so this is actually a picture I took, was if you conceptualise that you have this big body of water, which is your methadone dose, or your big body of heroin water, you're putting a tiny drop of buprenorphine into the ocean of that methadone or heroin dose. And each time we drop a little bit more in, it builds up in this big full agonist body of water. And the idea is you slowly, gradually build it up in the background, and as we gradually build it over time, there's a crossover that happens. And I remember the first time we did this on one of the wards, I felt so weird, because everything we'd been taught was you don't administer buprenorphine at the same time as methadone, or you don't administer buprenorphine at the same time as oxycodone. And I was like, so just so I'm clear, we're still giving the 60 milligrams of methadone? Yes, we are. With the buprenorphine? Yes. Great. And it didn't go pear-shaped. And we've been doing it for a while now, but the same principle remains. You build it slowly in the background until you hit a therapeutic effect dose of the buprenorphine level, and then you start to bring down the full agonist opiate of whatever else they might be using. And there is lots of different protocols that have been used. This is actually a case that's been brought out of the Bernese model. This is an American model of buprenorphine dosing for micro-induction. And this is, I get, for want of a better term, the typical micro-induction pathway, where we start with 200 micrograms of buprenorphine while the person continues to actively use heroin. And I think it's important to think about this not just in people who are doing high-dose methadone or methadone long-acting opioid transfers to buprenorphine, because the patients that I actually use this most with are people who are very tolerant heroin users who simply just cannot wait to go into withdrawal to start their buprenorphine treatment. It is just way too intolerable for them to struggle with that level of withdrawal. So we just say, keep using, just keep using, and we're going to trickle in these doses of buprenorphine. So this is the kind of typical one. The difficulty we've found outside of the inpatient environment with the use of sublingual Temgesic is you're doing complete private off-label prescribing, but it requires quite a heavy amount of monitoring to occur. The patient has to commit to coming to clinic every day, to taking a dose in front of you, checking in about their symptoms, walking away with another dose that they might take later. So it's quite time intensive. So I've moved a little bit away from this in terms of what we do in the community, but we definitely still use a similar one in inpatients. So this is the New South Wales guidelines that's come out, and this is around a methadone dosing crossover. And what's great is this is the first sort of guideline we have around endorsing micro-inductions and buprenorphine in Australia. This is a pretty straightforward process that actually works incredibly well, but again works on the idea of using sublingual Temgesic doses that start at around 200 micrograms, then 200 BD, then we move up to 400 BD, then straight into milligram dosing of sublingual film. The big thing to think about in all of these things is it's great for me to put the numbers up there, and I'll run you through some case examples of how we've done this, is that I find one of the biggest barriers to the transition points to the buprenorphine induction is the patient's perceived anxiety of precipitated withdrawal. So if they've had precipitated withdrawal before and they've struggled with it, the concept of physically taking something is quite terrifying. So which is why this is a pathway that I actually use a lot in community now, because there's a big psychological difference between using a sublingual preparation and a transdermal patch. We use a combination of transdermal patches and sublingual in inpatients at the Alfred. Again, I must be clear, this is all off-label prescribing, but this is actually something we got off Monash Addictions, which is their Norspan patch induction process. And what's fascinating is you can see after a period of time, you actually end up with quite a number of Norspan patches on in place. But again, because I love pharmacology, it makes pharmacological sense to use patches too. The peak onset time for a transdermal patch is 36 hours. So sublingual, you're getting effect within 30 minutes, 36 hours on a patch. So it's a really gradual induction onto the buprenorphine that you can gradually build over time and then convert over to sublingual before then if they're wanting to convert to LAIB. And this is kind of what we've now come up with the Alfred for transdermal patches. So what you can see is we start with 10 microgram patches, add in a second 10 mic, and it's every 3 days, which goes with the pharmacological action of the patches to slowly building to a point where they end up with 80 micrograms of per hour transdermal buprenorphine on them, which the really cool thing about doing it this way is by the time they've got the 240 microgram patches on them, you can reassure them that the total dose that they're actually got in their system at any given time once it's hit full efficacy on these patches is nearly 2 milligrams of buprenorphine anyways. So you're sitting at the realms that you would be transitioning to sublingual anyways. They're already tolerating it via the patches, and so then it makes that conversion over to the sublingual preparations a little bit more straightforward. This is a random one, and the reason I show this is because in hospital we do a variation on a micro-induction in inpatients that uses a ketamine cover as well. And so this is kind of something that was conceptualized in the United States. It's definitely not clinically endorsed, but it was a trial that they did using sublingual, which is their buccal Belbuca, buprenorphine over in the United States, while someone was treated concurrently on OxyContin for their acute pain and during the post-operative period. Again, with the goal being continue your acute analgesics and then do your transition over to buprenorphine in the background as their acute analgesic requirements subside. So these are my case examples of various different ways that we have done micro-inductions. So we had a very complex woman, Mrs. S we'll call her, who's a 56-year-old woman who had really significant gut problems to the point that we weren't clear that any of the morphine that she was taking, she was actually absorbing properly through her gut. So she was taking up to 400 milligrams of morphine daily, and we didn't know how much of that she was actually getting for her chronic pain with escalating clonidine, morphine and clonazepam requirements. She was actually brought in back to hospital with us at the Alfred, and I put this up because I use this presentation for some of my hospital in the home colleagues, because she's not the stereotype as well of what they would expect for someone who had a substance use disorder. And this woman ended up having a period of HIF home treatment, and they were really scared about meeting her. And I was like, she looks like a librarian, guys, it's going to be fine. So we brought her into hospital with our support from gastro and the pain services for the purposes of an opioid rotation. And this was a really strange process that we undertook, and it had to be very creative in what we did, because we had to be responsive to her anxiety around the opioid rotation process, as well as consideration for what was going on with her possible malabsorption in her gut, as well as how long it was going to potentially take us to do this crossover to buprenorphine. And whether or not in all reality the buprenorphine was going to work. She had a high oral morphine requirement, and there is a point where you can say, is buprenorphine ever going to get to that point? Is it really going to hit the same marks as the full agonist? So we started her off very quickly with a transdermal patch at 10 micrograms, as well as doing concurrent 200 micrograms as sublingual Temgesic. And we built that over the first couple of days. And so it was within 3 days that we had her going up onto Suboxone treatment. The different being here is that we were able to use ketamine as a cover in the background to ease her through this process. This is not something that's been clinically studied. This is something that we're trialling anecdotally to try and support people through their opioid rotation processes. But what you can see is that by day 12, we actually had transitioned her across to long-acting injectable BUP at 128 milligrams without any precipitated withdrawal as well for this woman, but had to use a lot of adjunct therapy. A much more straightforward process. So this was a woman that we treated at North Richmond, Mrs. F. So she was someone who had a long history of treatment on methadone via a community GP and had been transferred across to us. She'd previously been up to 100 milligrams daily, and had a long history of these awful lower leg ulcers, but kept having times where she would miss her methadone doses in the community for all sorts of different reasons. She was in pain, she couldn't get to clinic, she couldn't get to the pharmacy. So we'd spent a lot of time talking to her about whether or not LAIB would be more appropriate for her, and she really wanted to do it, but we just couldn't work out a way for her to do this. So eventually we went ahead with a micro-induction after she had a period of break, so we had to accidentally drop her dose anyways of her methadone. And she, as you can see, she stayed on her 60 milligrams of methadone the entire way through until day 6, as that was the first day that we actually dropped the dose, as we trickled in 200 mics of buprenorphine and then escalated up to 8 milligrams BD before we actually started to cut the dose of methadone. And then by day 8, she was transitioned across to Buvidal LARB 160. And so what is the limitations of all of this? That we have no consistent guidelines at this point. There is things starting to change and happen. So we have the New South Wales guidelines that are coming out. There is more information coming from the United States in terms of national stances on this. We have the issue of PBS off-label prescribing as a financial barrier. So a lot of our clients can't afford this in the community on private scripts, which is a big problem. I think when I was working out the costing for one of my patients recently, if they were going to do it with the transdermal patches, it was going to cost them at least $150 to $200 just to cover the cost of the patches. Which the argument which I had managed to have with my organisation, which wasn't Alfred Health, was that surely the cost of $200 for some patches is cheaper than if this person continues to use, gets really nasty infections, ends up in hospital again. So my service ended up agreeing to cover it. And also that there's a need for regular monitoring. And so there is a bit more ease of doing this within the inpatient environment, but there is definitely movement in this space to start doing more community-based micro-inductions, particularly for those patients who struggle to make that transition across. I think I've managed to absolutely nail my timing, because I think I was meant to do 12 to 12:45. So now I'm happy to open up for any questions.
So my name is Anushka Anand. I'm the Workforce Development Coordinator at VAADA. And so on the topic that we're going to be delving into next, chronic pain, substance use, and sleep, there's 3 things that are really deeply significantly affect a person's quality of life. So on that note, I'd like to introduce our next presenter, Lisa Jarvie. So Lisa is an experienced registered nurse, passionate about self-determination in healthcare, particularly for people experiencing complex and long-term health impacts. Lisa approaches her work aged care and culture change, Lisa came to the AOD sector after completing a Master of Addictive Behaviours, in which she completed a thesis in chronic pain, sleep, and substance use. Please join me in welcoming Lisa.
Thank you very much for having me here. It's a real pleasure to be here to talk about a topic I'm really passionate about, which is pain and sleep. As Anushka, thank you very much for that kind welcome. As said, I've spent 10 years working in the chronic pain area, and now having moved into mental health and addiction, I do miss pain a little bit. That sounds terrible, doesn't it? I miss working with people with complex pain and sleep. I'm sorry about the lack of a lectern is going to mean I'm looking down just a little bit. I'd like to acknowledge the people of the and to extend that respect to Aboriginal and Torres Strait Islanders here today. At the Hamilton Centre, we also acknowledge the contribution of people with lived and living experience to the work that we do in mental health and addiction, and personally I also acknowledge the experience of people with complex healthcare, including pain and addiction issues. So what's pain? This is one little sentence that caused so much controversy. When this came out in 2020, you can imagine, given it was an international association, that this caused a lot of controversy in general. Then when it came out, there was a lot of disagreement. It left lots of things out. And it does. It actually came with 6 explanatory statements. So even one sentence, they couldn't do it. We had to explain it some more. So pain is an unpleasant sensory and emotional experience associated with or resembling there, but it doesn't tell us very much. So we had to talk about pain being a personal experience, pain being impacted by emotion, biological, psychological, social pain. We had to talk about pain and nociception being different, and I'll talk a little bit more about that. We had to talk about life experience. We had to talk about individualisation of pain. We had to talk about the person's report of pain must be believed. We had to talk about pain serves as an adaptive role. It could have adverse effects on functional, social and psychological well-being. These are all the explanatory statements. So pain is not simple. Pain happens when you say it does, and it means what you say it is. So what really is pain? I'd love to live without pain, wouldn't you? Doesn't it sound like an idyllic way to live, without pain? Never to shout ouch, never to wince, never to feel the discomfort and ache of something wrong. Well, that's actually called congenital insensitivity to pain, and it does exist, but those people are very rare and don't tend to live beyond 25. And that's with constant monitoring to make sure that they're not accidentally injuring or really hurting themselves. But everyone feels the same with pain, right? No, pain occurs in all sorts of ways. Pain tells me when something's wrong, but if your pain persists, see a doctor. Well, we've all heard that. We've all been taught that pain occurs because some harm has occurred to our body. It's a sign there's something wrong, something out of place, something's being pressed, something's being pinched, and it makes a lot of sense. We're taught that as pain gets better, function returns and life goes back to normal. That's most people's experience of pain. It's the pain we learn as a kid, it's the pain we experience, it's the pain we see in other people. If our pain system worked really well, would we experience a silent heart attack? Would we detect cancer in someone who already has cancer throughout their body and is no longer treatable? Would we have a silent stroke? Would these life-threatening conditions really be painless at times? Not always, but at times. Why do they hurt less than a stubbed toe, a paper cut, or even worse, a stubbed toe on a cold day? They're the worst. Just imagine it, you feel like you've broken it. Our pain system is a pretty crude measure, and it tends to go into overdrive and be a bit overprotective. So, pain is real. Chronic pain affects about 20% of our population. Women more than men, older people more than younger people. And there's no test for it. We can't test for chronic pain, there's no measurement of it. There's no diagnostic test, it's based on a clinical judgment. I realise the green is really hard to read. So we'll read it out to you. Pain is real. It happens when you say it does, and it means what you say it means. It feels how you say it feels. Pain is a protective experience and it's essential for survival. Chronic or persistent pain, the terms are used relatively interchangeably. I tend to use chronic pain, but there is persistent pain out there as well. It's the same. We're talking about the same thing. It's an overprotective brain response, and it's unhelpful. In chronic pain, often medications become unhelpful. And I'll talk a bit about that too. Most people with chronic pain have been made to feel like they're making it all up. They've been told it's in their head. They've been told there's nothing wrong. So what really is pain? Biologically, what's going on in our body? We have lots of terms for pain and what it means. While this slide outlines what we think the pain system should look like, we acknowledge, remember back with that weird definition, we acknowledge that pain is individual and it involves all aspects of our brain function. Danger signals, so nociception, the difference between nociception and pain. Pain is a brain experience. Pain is a brain output. Pain is what we experience once signals have got to the brain and been interpreted. We don't have pain signals. There is no pain signal that goes from your foot to your brain. That's nociception. Nociception often gets turned into a pain experience by the brain. It's a different part of the nervous system. So danger signals, nociception, is sent up to the brain where the brain makes meaning of that. And the brain makes meaning of that in the setting of where you are, who you're with, what's your psychological status at the time, what's your social status at the time, what physical damage have you got going on. It's going to tell you lots of things, and your brain gets involved in lots of different parts of your brain to tell you what's going on. I want you all right now just to think about your left big toe. You might have to wiggle it to be able to feel it. Think about your left big toe. Is your shoe pressing on it? Is your sock feeling funny about it? Is it a bit sweaty because it's a hot day? Have a think about your left big toe. Was anyone in this room thinking about their left big toe before I told you to? You were? There you go. That might be because you have pain involved with it or something's uncomfortable. Your brain thinks you should know about it. But that's one. But now you're all thinking about your left big toe. That's because our brains have this amazing ability to zoom in and zoom out of what we think is important at the time. So most of you had zoomed out on your left big toe. You might have felt your shoes when you put them on this morning, but your brain then went, no, there's no danger. Our body sends our brain signals all the time. And it's our brain's job to think about what's important. So usually it filters out stuff that we don't need to worry about. With pain, we can look at that with the example of the soldier with a bullet in their leg carrying their mate off the battlefield to get their mate to safety. We think about the mum pulling their child out of a burning building when they're damaged themselves. We think about the footy player who plays with a lacerated spleen and some broken ribs. These are people who continue along despite the number of danger signals that their brain is receiving, because what's happening at the time is more important than their physical safety. Our brain can zoom in and zoom out, and that's really, really important when we're talking about pain. Chronic pain is pain that happens in the absence of damage. Really, that's a really challenging idea to understand. It's certainly challenging for clients to understand. It doesn't mean there wasn't ever damage, because someone might say, but I've got all this scar tissue there. Absolutely you do, and that's real. But it's not new damage. It's as healed as it's ever going to be. There's no new change happening to make you experience pain. There's no new danger occurring that you need to be aware of. And that's a really tricky thing to get your head around. Very broadly, we describe chronic pain as pain that lasts beyond the time frame of normal healing, which is about 3 months. If you've got a paper cut that's lasted 3 months, that's not right. You should go see your doctor. But if you've had a complex trauma, it might take longer than that, but generally we use about 3 months. Nociplastic pain is when our body and brain adapt non-painful stimuli, so non-nociceptive stimuli, to experience pain. So you might have the client that you can stroke their arm, and for someone else that might feel pleasant. For someone else still, it might feel annoying. Other people might pull away because they don't like being touched, but there are people who will feel like you are burning my skin off. I feel like you're doing that with a razor blade. So we've got non-harmful stimulus eliciting a pain response. That's where we're looking at a maladaptive nervous system. It's the car alarm that goes off when you walk past the car, not when you're trying to break in. So keep that in your mind about chronic pain. So how do we measure pain? We've all seen this, used it plenty of times. Visual analog scale. This is how we measure pain, right? Is it useful? No? Yes? We do this in the hospital to measure acute pain. This is the pain that we're expecting. The pain will resolve, function will return, and the person will go back to normal. This is what we use. As I said before, we can't diagnose chronic pain based on scales, based on tests, based on imaging. About 50% of us over 40 are going to have fairly significant spinal degeneration. And of those people with changes on a scan, 50% of them will have pain, 50% of them won't. And of everyone who doesn't have changes on a scan, 50% of them will have pain, 50% of them won't. It doesn't mean anything. So what we see on imaging doesn't tell us anything about chronic pain. So how do we know what's worse when we're looking at chronic pain? This doesn't tell me anything, because I might wake up one day with 8 out of 10 pain doing exactly the same thing I did yesterday when I had 2 out of 10 pain. Or I might have no pain whatsoever and be not able to function, or have great function and still have pain. So pain and function don't marry together in chronic pain. What instead we tend to talk about is pain interference. So pain interference, so this is called the brief pain inventory. You may or may not have come across it, but the brief pain inventory is a commonly used validated tool. It's part of the chronic pain toolkit. Everybody going to a pain clinic will be doing multiple BPIs over their time there, generally at admission every few months through their recovery at discharge. So we get lots of BPIs on people with pain. We get a range of scores for pain severity and a range of scores for pain interference, and then you get a global score for both. It looks at mood, how pain affects your mood, your walking ability, your paid and unpaid work, your relationships, and your general enjoyment of life. So pain interference is that which stops you doing what you love doing or stops you engaging with life in a more broad way. So pain interference is a much more clinically meaningful tool when we're looking at chronic pain. But I said I'd talk about sleep too, right? So far I've only talked about pain. Has anyone seen a sleep cycle like this before? Or is new? Just a couple of nods? Yep. So why am I talking about pain and sleep? I'm hoping that that'll become a little bit more clear over the next little bit. Sleep disturbance and chronic pain are both considered public health concerns. So I've mentioned that chronic non-cancer pain, and I say non-cancer pain because cancer pain is an entirely different beast. So when I'm generally talking about chronic pain, I'm talking about chronic non-cancer pain. It affects about 20% of people, more women than men, more as we get older. It's the leading cause of disability globally. Disordered sleep has significant human and economic impact, with insomnia alone associated with functional impairment and increased disability. So if we're adding the biggest disability impact plus insomnia, you can imagine then we're getting even more increased disability. Sleep disorders cost Australia $14.4 billion in financial costs and $36.6 billion in non-financial costs in 2019-2020 alone. That was according to the Sleep Health Foundation. So there's a high disability cost and a high financial cost associated with these conditions. Sleep is absolutely essential for brain function. So remember, pain is a brain output, sleep is essential for brain function. The stages of sleep have different functions in our body's restoration, and they're all important. This cycle is what we describe as sleep architecture. So this is how your sleep is built through the night. Broadly speaking, we talk about non-REM and REM cycles. So REM sleep is generally when you dream. Non-REM sleep or slow wave sleep spindles or rapid bursts of high frequency brainwaves. And the deepest sleep we have is when we encounter delta waves or those hypnotic slow waves that are also induced in relaxation states or hypnosis itself. REM sleep, or rapid eye movement sleep, as I said, generally when we dream. And you can see in this picture that the longer we sleep, the longer our periods of REM are, and the less deep sleep we have. So you'd think somebody with chronic pain needs lots of deep sleep, that physical restoration. I'll talk to you a little bit why it's kind of the opposite. REM sleep is about 25% of our sleep overall, and it can help with emotional processing, feeling rested and able to take on new information every day. Non-REM sleep, or that deeper sleep, is more physically restorative. Once you're sleep deprived, your body thinks you need more physical restoration, so it tends to put you into more deep sleep and less REM sleep. So the more sleep deprived you are, the less REM you get. The less REM you get, the more sleep deprived you are, and the more deep sleep you get. Substances like alcohol can also reduce REM early in the night. So if you're only getting a short sleep, after a time of using alcohol, you're probably getting very little REM sleep at all. And some of the most common sleep disturbances do include insomnia, which is characterised by either being unable to sleep, difficulty falling asleep, or difficulty staying asleep. It increases daytime drowsiness and really affects mood. Incredibly commonly in Australia, and more so in people with pain, we see obstructive sleep apnea. So OSA can be caused by a range of issues, but it is characterised by a partner or a family member tells them how bad their snoring is. With severe sleep apnea, you may need to use CPAP, which is continuous positive airway pressure, which is a device you wear at night to help support your airway, so you can keep getting oxygen overnight. There's varying levels of wanting to use those things. A lot of people are not very, I hate using the word compliant, it's a terribly stigmatising term. A lot of people really don't want to use them because they're not very comfortable and they dry out your airways. So there are lots of new ones on the market, but CPAP is a difficult thing to have to use. Obstructive sleep apnea is also linked with chronic pain. It's been hypothesised to be in conjunction with increased body mass index and opioid use, but it's actually in fact still seen at greater rates in the absence of those factors. So there's an independent link between OSA and chronic pain. Insomnia is seen as, has been known as a risk factor for the development of chronic pain as well. So we're starting to see those links between pain and sleep. So coming out of my master's, or coming into my master's, I decided I wanted to look a little bit more at pain and sleep, but also how people use substances with relation to pain and sleep. So I worked with the team at the respiratory lab at Eastern Health with Rowan O'Gell, who's one of the senior lecturers at Monash University and Turning Point, who was my supervisor and to whom I am eternally grateful. And we looked at measuring the prevalence of, so CNCP is chronic non-cancer pain. So the prevalence of chronic pain in people undergoing polysomnography, that's a sleep study, all the wires and all the monitoring. And we looked at the impact of sleep architecture. I was very lucky to get the confidence and trust of 15 people with pain in that cohort who also sat with me and did an interview about their substance use and their pain and their sleep. So but in late 2022, we looked at the results of 245 individuals, all adults. There were no specific exclusion criteria as long as they had more than 180 minutes sleep in the sleep study. Less than that was not really worth including. So we looked at demographic information, pain and sleep questionnaires. So the BPI, the PSQ3 is the pain and sleep questionnaire. So it's a 3-item, how bad does pain affect your sleep? And we looked at the PSQI, the ESS, which is the Epworth Sleepiness Scale, which looks at how sleepy you are during the day, the audit, which hopefully you all know, the Alcohol Use Disorder Identification Tool, and the HADS is an anxiety and depression scale. They underwent a normal one-night polysomnography, and 15 people are happy to have a chat with me. So we found that 60% of this population were positive for chronic pain, indicated positively. We used either a simple, because remember I said there's no test for it, so it's really hard to do a questionnaire and find out if people have pain or not. So what we did was used at the top of the BPI, gives a description of what sort of normal everyday pain is and asks, have you had pain that's not that? So we used a yes on that, and we used 75 millimeters on the PSQ-3, which is showing that pain affects your sleep. So we used those two as a bit of a crude measure. When we went back and compared our chronic pain cohort with people seen in pain clinics, they were really quite similar. So it sort of validated our crude measurement of who had pain and who didn't. So 60% of them screened positive for pain, but 72% of women. So in our cohort, we didn't have 20%. We had 72% of women, 60% overall. I think it was 45% of men, so it evened it out. But it's even at 45%, that's double the population average, more than double. They were more likely to be older, have a higher BMI, and they were more likely to rate their sleep pretty badly, fairly or very bad. But there were no differences in sleep architecture. It was a little bit disappointing. But then I looked at those BPI results and realised pain severity and pain interference weren't very high. They were about 3.5, so in the mild end, sort of upper end of mild. So instead we decided to look at what would be clinically meaningful. So clinically meaningful interference is about 5+. This is really busy, so I'll leave it up for a little while. We took people with pain interference 5+ and looked at their sleep architecture. They had longer REM sleep latency. That means it took them longer to go into REM sleep full stop. They had reduced REM sleep, so their percentage REM sleep was lower. They had higher Epworth sleepiness score and higher AHI. So an AHI of 5 is indicative of obstructive sleep apnea. That's your obstructive sleep apnea measure. And as you can see, our pain group had an average of 40, so quite high. 94% of this group had indications of sleep apnea. In our pain group, it was about 75% of controls. And you've got to understand, this is a tertiary sleep lab. This is what they're screening for. So this is sort of almost expected, but no, it was a significant difference between the groups. Interestingly, audit score was lower in our pain group than in our controls. But as you can see, 3.5 and 2.1 are pretty low. There weren't great indications of risky alcohol use in either group, so we sort of took it out of the picture. We know that chronic pain is linked with OSA, and OSA can decrease REM sleep. So we needed to control for that. Are we actually seeing differences here because of OSA and not because of pain? So what we did was using pain interference as the dependent variable. We used age, gender, depression, anxiety, BMI, AHI, percentage of REM sleep, REM onset latency as independent variables. The significant individual predictors were depression and REM latency. So we had a sleep architecture element that was an independent predictor of pain interference. It's also important to recognise that 16% of these people with pain didn't experience REM at all. So in more than 3 hours sleep, they had no REM sleep. So that's 8 people, and that was in comparison with 2 in the control group. So it was a significant difference, 16% versus 2%. For the people that I chatted to, who were very generous with their time, and they, through the 20 to 30 minutes I had with each of these, it really proved to me how quickly you can build rapport and have really meaningful conversations with people. So I thank them in their absence for the generosity. Most of them had had pain for a long time. They thought their insomnia was related to pain, not the other way around, which is mostly interesting as those unhelpful thoughts around sleep and pain. So it's what we're taught, that sleep is a normal consequence of having pain. That's what people think, that their poor sleep is just a symptom of pain, and if I fix the pain, then I'll sleep better. That's a very common thought. We only had 4 people in this interview cohort who were taking prescription opioids, but the average OMED was 88.5, so it's quite high in the people that were. There was 1 individual who was over 160. No one was engaged with a pain clinic. And only 1 person was using any psychological strategies for managing pain. No one was taking prescription sedatives. So I talked to them about substance use. It was really common to be, I don't like the term misuse, and I'm sorry I didn't edit this slide. It's a little bit old. Non-prescription use of medications was really common. So we had 2/3 of people who either had non-prescription use of prescription medications or had tried cannabis. 6 had used alcohol in order to self-medicate sleep or mood, with a number taking medication or cannabis prescribed to someone else with a bit of a try before you buy attitude. It was the, I don't want to have this conversation with my clinician because it's too hard. I don't want to be stigmatized because I want to try something. I don't want to have a conversation. I just want to give it a go. And if it works, then I'll have the hard conversation. So that was sort of the attitude around trying things. And that was really with a sense of shame and self-stigmatization. Now, we know that non-prescribed medication use can lead to an increased risk of drug-drug interactions and a safety risk, especially if it is undisclosed, particularly with a group of people with complex health conditions. So we may have a number of medications on board and not just medication for pain. It also can, if it's disclosed though, it can lead to increased stigma and judgment between that clinician and the person in the room. One person in particular was describing how his wife now manages his medication. He no longer trusts himself. After a significant incident of trying to maintain pain where he ingested half a box of endone, he moved to a blister pack and was continuing to take more than prescribed because he just didn't know what else to do. So now he gives everything to his wife and he feels very disenfranchised with his own care. It was a bit of a sad story. This guy's was only in his late 50s. There's a long time more for him to be managing pain and medication. As I said, only one person was engaged with psychological strategies, and that's despite the primary gold standard of treatment for both pain and sleep is CBT. So a psychological strategy is the gold standard for managing pain and sleep, and no one was engaged with CBT. CBTI, or CBT for insomnia, is the best sleep treatment. CBTI works better for pain than CBT for pain, which is really interesting. And that was done in a pain population, not a sleep population. So CBTI, you could almost say, is the gold standard for both. So why aren't we using CBTI? Why are we medicating? Why are we prescribing? I wanted to read you out. I have done a thematic analysis on some of the themes coming out of this, and the overarching themes were dissatisfaction with clinical outcome, financial disadvantage, life stress and function, physical changes, and non-medicinal coping. Some of the comments around non-medicinal coping, or the sub-themes, were worries about dependency. My mum was addicted to pain medication and she had trouble sleeping, so I just don't want to go down the medication thing if I can actually help it. Impact of medication on function. I literally couldn't function for nearly 6 months because I was so bombed out. The interaction between alcohol and medication. Oh, Jesus. I don't know how to, sometimes I used to drink to go to sleep, but you can't drink with these tablets. I'd be catatonic. Alcohol use more broadly. I certainly had 2 or 3 glasses of wine every night with dinner. That would not be enough to really get a buzz on, but it was something I did because, I don't know, it just felt a little bit better to do that. And then openness to cannabis use. I did have some cannabis overseas, like in the oil form. I found that quite helpful. With the regulation here, it's sort of out of reach over the counter. If available, it'd be something I would definitely try as a sleep aid. So we had a number of comments and really great information that we got from some very generous people. So, talk about pain and sleep with all of our clients. Whether people are presenting relating to prescription misuse of prescription medication or non-prescribed use of prescription medication, presenting for sleep or presenting for pain, we need to be having conversations about all of those things with clients. They're very, very linked. I have been working with pain and sleep clinicians to get the word of this out there. A lot of this information was presented this year at Sleep Down Under, which is a national sleep conference. It has also been presented at the APS conference, which is the Australian Pain Society. So I am talking and trying to get the word out there, and there's a lot of interest. Respiratory physicians particularly were gobsmacked different because they do work quite closely with Turning Point, but there's not a lot of conversation happening cross-discipline. We need to be considering pain when investigating sleep. So sleep clinics need to be involved with this. I also have to say that as a limitation of this study, I'm very aware that this was one-night polysomnography study. Particularly for people with pain, we need to be able to replicate this in their own home. We need to be replicating this where people are or having multiple nights in a sleep clinic so that you feel more comfortable and more likely to have a more normal night's sleep. So there are elements of potential risk in there, of doubt. But we should be considering pain when investigating sleep, particularly in women. We need to be looking at REM latency. So we need to be looking at specific targets for CBTI. We need to be thinking about the lack of REM sleep. Those things about managing distress with pain are going to be much more hard to do when you're not getting REM sleep. So when people with chronic pain are chronically not getting REM sleep, they're less able to manage the distress around pain. So we've got this vicious cycle going on that we don't even think about. Also consider issues related to memory when people have insufficient REM sleep. So in insufficient REM sleep, we need to be thinking about providing written information, letting people record your instructions, writing it down for them, giving people online links to follow, but making sure that we're not expecting people to remember everything that you've said in a consultation. Early engagement with CBTI. Now, CBTI is a little bit hard to find. Not every psychologist is an expert in CBT for insomnia. Reconnection do a great CBTI. That up beyond benzodiazepine use as well. So obviously Reconnection is primarily set up to help people manage benzodiazepines, but they also have a CBTI program, which is a great program. We need to be really aware that non-prescribed use of medication for pain and sleep is common and it's normal. We need to normalise the desire to fix our pain and our sleep. And that sometimes all we can think of, oh, well, this works for my pain. So if I just take more of it, or I just want to go to sleep. So if I just take more of it, I'll go to sleep. Or if I have a few drinks while I'm having my endone, I'll be able to go to sleep. So there's a lot of that thinking, and it's normal and it makes sense. It's common. 2/3 of the people, remember, we had 2/3 of 15, and these were not people engaged with pain clinics. A try before you buy perspective is also common and normal. Having those conversations up front, oh, you might be really tempted to try things. We get it because it's normal to want to control your pain and sleep. If you're tempted, can you just let me know? Because if there's an interaction with any of your other meds, then we can have a chat about it before you try it. It's destigmatising that wish to try things out because it potentially exposes risk to that drug-drug interaction. And we need to know, particularly if people are on opioids, you might want to make sure they have access to Nixoid. You might want to think about what are the potential damages that this person could encounter with sort of lack of supervision around this drug sort of trying in relation to pain and sleep, especially if they're not engaged in CBT programs. Which is why we need to do the education about potentially risky use early and often. And it's not just the job of the AOD clinicians, it's the job of the pain clinician, it's the job of the sleep clinician, it's especially the job of the GP. Most of these people were having medication prescribed by GPs, and that's where that needs to happen. And in pharmacies. Oh, I've noticed that you're on this, you've just been prescribed this. This is what we find, it's really common to want to try things out. So having those conversations early and often can help protect people. And we really need to get people into CBT programs instead of prescribing. That's the end of it. Oh, not having to do that. Are there any questions? Happy to take any or all.
Sorry, I'll bring the mic so our online attendees can, yeah.
just wanting to ask, like, have quite a few patients that come through that use cannabis or alcohol, and their primary use, I think, for continuing use is the sleep interruption. Have you got any sort of, I don't know where to send these people, because we talked to them about the GP, we get the eye roll, you know, all that sort of stuff. And I realise that, you know, it's probably a large privatised sort of industry, is it?
Yeah, there's a lot. So a lot of the CBTI practitioners are private psychologists, which obviously puts them out of financial reach of a lot of people. But there are major hospital clinics who also specialise in sleep psychology. But there are also online programs. So if people don't have access to a person in front of them, I'm trying to remember off the top of my head which organisation did it, but they've done the CBT for pain, the CBT for sleep, and they're online self-directed programs. They can sign up with a clinician there, so you get reports and you can have it feed into therapy as well. But I didn't even touch on sleep hygiene. So there's a lot of things that people can do at home for themselves to try and improve sleep. And they might not look at substance use change at the same time. We don't want to take away people's methods of managing sleep and pain, because it's obviously giving them distress. So if we're increasing distress, then we're going to be doing everybody a disservice. So that's where I start one thing at a time. So to be one thing about sleep hygiene. So there's lots of stuff online about that too. I could talk for a whole hour on sleep hygiene, but essentially it's looking at your environment in which you're sleeping. Look at how do you use your bedroom? So for people with pain particularly, they might go to bed to manage pain. And because our brains are amazing and really highly neuroplastic, if you go to bed to manage pain, then you go to bed and your brain goes, oh, we're in bed, pain, bed, pain, pain, bed. So as soon as, even if you go to bed to go to sleep and you're not experiencing pain, as soon as you hit bed, pain. It's the same sort of thing as if you have your thoughts race when you're going to bed. Oh, I'm going to go to bed and my thoughts are going to race. Oh, there's no point me going to bed because my thoughts are going to race. Go to bed and what's going to happen? Your thoughts are going to race. Our brains are amazing. So we need to manipulate our brains, use that neuroplasticity in our favour. So part of that is going in, and it might be doing a bit of an overhaul of your bedroom. So that's often the place that I start with people. Stop calling it a bedroom and start calling it a sleep haven. Do you walk into that bedroom and go, oh, I love this space? Like, is it somewhere that or do you have the washing on the end of the bed? Is your partner messy? Does the dog leave dog hair all over the bed? Like, thinking about your sleep haven. I've just called out half the room and myself. My partner is messy and it drives me nuts. But having a think about your sleep haven and how does that work for you? And that can often be just the starting point to put the value back onto sleep. But there are some great online programs. I wish I could remember it off the top of my head.
Thanks, Lisa. We've got a question online from Nick. Is melatonin widely discussed? Can you touch on melatonin?
So melatonin obviously is a naturally occurring hormone. As your melatonin goes up in the night, that's when you feel sleepiness. So this is, part of that other sleep hygiene talk I would do. So melatonin is a really important sleep hormone. As melatonin rises, we get sleepy, we go off to sleep, and that's how it's meant to work. So some people do take melatonin. You can take melatonin on prescription. A lot of people just buy it online in varying doses. There's not a lot of evidence around the different varying doses, but you can get anything from 1 milligram to, if you buy it online, you can get 10. Generally, a prescription here will be for 2 milligrams. You can get slow release and immediate release melatonin. So there's a range of different formats you can get it in. Essentially, you would use melatonin as a circuit breaker. So the idea behind melatonin, it will take a few weeks for it to build up in your system, but you don't go on to melatonin to be then something you're on for the rest of your life. So you go on to melatonin while you're practicing all of your sleep hygiene strategies, while you're learning how to manage pain, while you're putting into practice a lot of the other things you're learning. You might go and use a sleep aid like a melatonin for that period of time. The problem with taking naturally occurring hormones is that then our body goes, oh, we don't need to produce that anymore. And then if you come off the melatonin, your body doesn't produce enough melatonin anymore. So using it for a short period of time while you're implementing and learning other strategies can be helpful, but certainly wouldn't be recommending people to go and just try melatonin without having a discussion with a physician or with a nurse practitioner or with with a sleep specialist. It should be used in a strategic way. I hope that helps. And I would say the same for any other sedative. So use of benzodiazepines for sleep, etc. 2 weeks. It shouldn't be a long-term thing. If you've got a client who's been on benzos for sleep for 20 years, it's not doing anything anymore. So there's a lot of, and that's, I'm sure you've all got people who've been on benzos for 20 years, especially if they've been on the same dose of temazepam for 20 years, it's not doing anything anymore. 10 milligrams, 20 milligrams. But taking them off it, obviously you're going to wind up with withdrawal symptoms. So that can be really helpful with places like Reconnection, can then work on benzodiazepine reduction and sleep hygiene and CBT for sleep. They can do all of those things there. They are going to hate me because their phones are going to ring. They're incredible.
There any more questions?
Hi, I just had a quick Google and I've seen that there's a few like apps or programs that have been developed by like Ivy League universities in America based on CBI. Would you recommend them, or what are your thoughts on that?
Without having seen them, they're probably pretty good. Generally, the CBT principles and CBTI principles are pretty universal. So as long as they're evidence-based and user-friendly, yes. There was a question I was kind of expecting that I haven't got, which is like Apple Watches and use of sleep tracking devices. They're getting better, but they're not great. And often instead they can create a hyperfixation on sleep, which then causes increased anxiety around sleep. So if you or someone you look after wakes up in the morning and goes, oh, I had 3 hours of REM sleep, or whatever it might be, it's not actually, it's not a PSG, it's not polysomnography. It can be interesting, but if we put value and weight on it, it can create unnecessary distress. So I don't tend to encourage that routinely either. They are getting better though, and hopefully one day they'll be really good, really good. Oh, that's good. 11 hours in 7. That's a miracle. Would that we could all do that. Time traveler. Yeah.
Any other questions? Oh, yep, Scott.
Thanks, Anushka. Judy asks, a common one that clients mention is alternate leaf. Alternate leaf?
I don't know. Is that a trade name?
It's got a capital A. So, okay, so we're hearing from within the room, Daniel, thank you. It's prescription
It's a
cannabis.
Cannabinoid, yeah. There's mixed evidence. The evidence around cannabinoids and chronic pain isn't great. It's not a long-term, it's not going to fix chronic pain. I think what I didn't come back to it a lot was medications for chronic pain being unhelpful. Chronic pain isn't going to go away. So if you've got a 20 or 30-year-old person who's presenting with chronic pain, we need to have lifelong strategies, and medications are not lifelong strategies. Medications are things we can use in the short term, and I put this in the same category, so I'm sort of trying to answer that question. Any medication used for pain is in the short-term category of while you're learning other strategies. And the same goes for even for nerve blocks and things like that. They're not actually designed to last forever. For sleep, I would say the same thing, because there's going to come a point of tolerance. So when you're tolerant to medications, you just need to keep increasing your doses to get the same effect. And then at some point, you're dealing with side effects, but you're not getting any beneficial effect from that medication anymore. So yes, medications have a role, but do they have a lifelong and long-term role? Somewhat, I would say no. And if that's a bit controversial, I'm happy to be a bit controversial. That's why the top line treatment for pain and sleep is CBT. Because we need to change our experience and use our neuroplasticity to change the way we live alongside pain and sleep disturbance.
Just wondering about sleep consolidation.
Do you mean like sleep catch up, or?
Yeah, so compressing the actual amount of time people stay in actually sleep.
I missed half the question. Was that sort of compressing the amount of time?
Yeah, I think it's called sleep consolidation. Sleep consolidation, I think it's called.
It's not something I've come across very much. We've worked more with people around sort of natural methods of managing sleep.
So I think it's part of CBTI, whereas they'll try and.
So often with CBTI, when people struggle with sleep, particularly with waking up during the night, they tend to stay in bed for long periods of time. Is this what you mean? And instead of doing that, it's about setting a certain amount of hours that you're in bed to try and maximize that time. Is that, yeah. Yep. So it's trying to train our body. And some of that is done with sleep phase shift issue. So if you've got somebody who doesn't sleep till 4 o'clock in the morning, they sleep till 12 o'clock, and that's their natural sleep regime, but they want to sleep at night because they want a job that goes 9 to 5. So obviously, and part of that is being super aware of their body signals. So consolidation works if you go to bed at the right time, which is when you're going to go to sleep. So you might notice in the evenings, and maybe you can all do this tonight, you'll notice there are times when you feel really, really sleepy. And then if you don't go to bed then, you're going to be awake for the next hour and a half. That's because our sleep cycle happens all through the day. So our hormonal cycle that induces sleep is constant, and it's about 90 minutes. So if you have that wave of sleepiness at 7:30, you probably 9 o'clock will be your next one. But if you miss your 9 o'clock, then there's probably not much point going to bed at 9:30 because you're going to be awake again. So 10:30 would be your next one. So it's thinking of those. So if you're doing consolidation, you need to make sure that you're really listening to the body's signals as well, going to bed at the right time, and then making sure you're getting up so you're not staying in bed. Does that make sense?
Judy asks, if someone goes to bed but can't sleep after, say, 40 minutes, would you recommend they get up and do something?
Absolutely. Yep. So that's when we're looking at that 90-minute sleep phase. If you do put off going to bed at that 9 o'clock sleepiness phase and you go to bed at 9:15, and if you missed your window, there's absolutely no point staying in bed. Get up. Otherwise, you're associating your bed with tossing and turning, can't sleep in bed. So then we're training our brain to think can't sleep in bed. Get up, read a book, low light. Don't get into your phone. We're all guilty of that. Or have your phone in night mode so you're not putting, hitting your retina with the light that's going to stop your melatonin production. Didn't get into all of those things. This is all, again, part of that sleep hygiene. If you can't sleep, get up, do something else. When you feel the next wave of sleepiness, go, okay, it's time for bed now. The more we stress out and toss and turn in bed, the less likely you are to get to sleep. Get up, do something quiet, read a book, go back to bed when you're feeling a bit sleepy. Same thing if you wake up in the middle of the night. So if you're looking after someone, or you are yourself somebody who wakes up several times a night, if it's just to go to the toilet, try and do that in the dark as much as possible with a little low light thing. Don't turn all the lights on because you'll wake yourself up. And then go straight back to sleep. But if you just wake up and you're awake, bolt awake, do something for an hour and a half before you feel sleepy again, and then go back to bed. So yes, agree with you, Judy. Absolutely.
Thank you so much, Lisa.
Thank you.